Good evening and thank you everyone for joining us today. I am Amit Saxena along with my colleague Dr. Dipika Chabra from Medical Services, Mr. Sandeep Thapar, Zonal Sales Manager, and Mr. Yogesh Sudan, Regional Manager from Jagsonpal Pharmaceuticals are pleased to welcome you all to this ISAR theme webinar on recurrent pregnancy loss organized by Haryana chapter of ISAR ISAR with Jagsonpal Pharma as academic partner, makers of DIVATRONE 10 mg tablet, fully indigenized micronized dydrogesterone, maintain 250 and 500 injections, hydroxyprogesterones, and Recurrent Preg sachet containing L-arginine, lycopene, and DHA. We would like to express our gratitude and warm and hearty welcome to esteemed experts and attendees attending today. And we kindly request you to please post your questions, queries, suggestions via text in Q&A box or chat box. Please note this webinar is streaming live on Facebook and the link is already being shared in the chat box. To refer these webinars in the future, please visit our YouTube channel, Jagsonpal Medical Insights. Jagsonpal would like to express our gratitude for Dr. Renu Chugh ma'am and Dr. Rakhee Malhotra ma'am for this webinar as academic partner. Dr. Renu Chugh ma'am, she is a consultant IVF specialist at Chugh Maternity Multispeciality Hospital, Bhiwani. She is the President Foxy Branch, Bhiwani 2021 to 2023, President Haryana ISAR Chapter 2021 to 2023, and has recipients of many awards. Dr. Rakhee Malhotra madam, she is Director of AAS Fertility and Maternity Center, Rohtak, Haryana. She is Secretary of Haryana Chapter of ISAR, Joint Secretary of Haryana Ops and Gynae Society, ISAR. I request Dr. Renu Chugh madam to kindly initiate this session.
Thank you, Mr. Amit, for your kind introduction and helping us to organize this webinar. Good evening and namaskar, dear all dignitaries, guests and delegates. I really feel privileged to extend my warm welcome to all present here for this themed webinar hosted by Haryana chapter of ISAR along with the Central ISAR on the topic of RPL. All of us are either gynecists or IVF specialists and are dealing with such type of patients in routine in our day-to-day practice. In the end, we are in a dilemma what to do because we can't reach at a conclusion, and the best thing you do, still you are frustrated in the end because many of these patients, they are unexplained and you have to put them on empirical treatment and in the last, tender love care. So dear friends, to remove all your doubts and queries, we have with us today eminent speakers, intelligent and sharp moderators with their team of analysts who will be helping you to take you through the journey of RPL. Today, I am profusely elated to take an opportunity to welcome and introduce such a noble personality, Dr. Nandita Palshetkar. So Dr. Nandita, she has been very kind enough to accept our invitation and sparing time in spite of her busy schedule. Ma'am is very humble, affectionate, and down-to-earth personality. And of course, she is full of knowledge with so many awards and achievements to her credit. And of course, she is a mentor for the upcoming gynecologist. At present, she is a worthy president of our Central ISAR 2022-23 and other achievements awards. You can see on the screen, they are displayed. As seen, we can have a look and just make out that she is at present working in Mumbai as a consultant, as a advisor, as an examiner, has been past president, present presidents of so many national and international associations recipient of Bharat Gaurav Award, IMA Award, and so on. And the most important, she is Super Achiever Award she won in 2009. So for that, she has been given a special designation, a lady with brain and beauty. I must say that. So ma'am, again, my admirable welcome to you. And maybe when you join us, we'll have few words from your side. So thank you everyone for patient listening. Now I hand over the mic to Dr. Rakhee to introduce other two guests of honor, Dr. Punita and Dr. Alka Kriplani. Over to you, Dr. Rakhee.
Thank you, ma'am. Thank you. On behalf of Haryana chapter of ISAR, I have a great honor to welcome Dr. Alka Kriplani as a guest of honor. She is a renowned personality, a very renowned laparoscopist. She has a many professional associations, FOXY, DGS, AOJD, JESI. She has, in credit to her, about total 47 awards. She is Padam Shri, got Padam Shri for Distinguished Service in Medicine by President of India 2050, and to add to many more awards like BC Roy Rush Award and many more. At present, she is working in the Paras Hospital in Gurugram, and she is a great laparoscopist. And I welcome you, ma'am, and thank you for sparing the time for this webinar. Take a privilege to welcome our next guest of honor, Dr. Punita Hasija. She is the President IMA Haryana State. I'm feeling really proud to introduce to you, ma'am. Thank you so much for sparing your time. She is alumni of PJ Rohtak, and she's at present doing private practice in Akriti Nursing Home in Faridabad. She has Vice Chairperson North Zone, and she is associated with so many associations, and she has done a great job for the IMA Haryana. I really thank you, ma'am, for sparing the time. Please, we want to have a word of wisdom for you, ma'am. Welcome you, ma'am.
Okay, good evening, everyone. Thank you, Dr. Renu ma'am and Dr. Rakhee ma'am for inviting me to this prestigious forum. And the topic is really very nice and very day-to-day importance. We definitely see so many patients of recurrent pregnancy loss, and we are also lost in how to treat and how to do with this patient, because each patient behaves in a different way. So I think we will listen to our eminent speakers, and from our chairperson, we'll have so many crisp questions, and we will be enriched on this topic. Thank you once again, Dr. Renu ma'am and Dr. Rakhee ma'am and Chapter ISAR Haryana. Thank you so much.
Thank you, ma'am. Now let's start with the session 1, and for this I would like to invite our the chairperson of Haryana chapter of ISAR, very dynamic, very kind, very humble and very cooperative, Dr. Renu. May I invite you to start the session 1?
Sure, Dr. Rakhee. I think it's time to start the session. Let me thank Dr. Punita as well. She has been very kind enough to join in time. And we are blessed that we have a lady IMA president in Haryana. So we can talk to her without any hesitation. So ma'am, I am sure you always be there to help us.
Yes, ma'am.
Especially-
Anytime, ma'am.
Yeah.
Anytime. Thank you so much, ma'am.
Thanks for joining us, ma'am. Okay, now let's start with the session. And before we start, I think let's have a small prayer with the lighting of lamp.
Shubham kurutvam kalyanam arogyam dhanasampadah shatru buddhi vinashaya deepajyotir namostute deepajyotir namostute.
Welcome back again. Now, thanks everyone. Now I would like to invite and introduce our chairpersons for the first session. So they are Dr. Chanchal, Dhir and Dr. Anita, Narula. So first I would like to introduce Dr. Chanchal, Dhir. She is a good friend of mine, first of all, and very humble and honest. She is in practice for the since 1987, life member of so many associations and zonal coordinator Haryana Harbo-Gynae, past president Bhimani OBG-Gynae, and she has special interest in endoscopy and ultrasound and colposcopy also. Dr. Chanchal, please over to you. Please introduce speaker Dr. Sujata, and later on we'll introduce Dr. Anita Narula, who will in turn introduce Dr. Isha. Okay, over to you, Dr. Chanchal.
Good afternoon, everybody. All I can see. And congratulations, Dr. Renu and Dr. Rakhee for holding this ISR Zoom meeting. And today, in this very good afternoon, I would like to, it's my privilege to introduce Dr. Sujata, who is renowned, gynecologist and endoscopic surgeon from Odisha. And she's Honorary General Secretary of Central ISR. And she has been practicing ART and gynae endoscopy since the last 27 years. And she is holding many publications to her credit, and she has earned many awards for her excellence in profession. Today's topic of her talk is consensus and controversies in recurrent pregnancy losses, which is a very important topic for all the gynecologists and obstetricians, and we would like to hear more from her and enlighten our knowledge. Over to Dr. Sujata.
Thank you, Dr. Dhir, for your kind introduction. I think firstly, a big thank you to Dr. Renu, Dr. Rakhee for, organizing this themed meeting, which was, I've been, so overwhelmed that we could organize this because it was in a short notice. It was very difficult to hold physical meetings at this time, especially when the annual ISAR was there. So Dr. Renu, Dr. Chugh, Dr. Renu Chugh and Dr. Rakhee Malhotra, thank you very much for this themed CME. As you all know, every month we have one themed CME. We have one theme from Central ISAR. This month it is recurrent pregnancy loss, and our Haryana chapter, our Rajasthan chapter, and our Delhi chapters. 3 chapters are doing this theme for this month. So thank you once again. Now let me jump back to my topic, which is controversies and consensus in the management of recurrent pregnancy loss. Now, Dr. Renu actually in her introduction summarized the entire management and diagnosis of RPL by saying that it is most frustrating to do that. It's true. And I will like to say that managing RPL is more about knowing and being knowledgeable and less about actually doing. So this saying goes the best, which says what your brain doesn't know, your eyes cannot see. So if you see this image, different people will see differently. You may see a scenery, but you will know that this is a fetus only if you know that there is a fetus image here. So basically, to manage RPL, you have to know what to look for, where to look for, and how to look for. Whether you can manage or not is another matter. So some interesting statistics, just to make it interesting, I will start with. We know that about 1% of women of reproductive age group have RPL, which is more than 3. Recurrence risk and subsequent outcomes are similar in women who have 2 or more. That is why definitions say that you can define RPL after 2 subsequent losses. First trimester losses are about 75% and second trimester are about 25%. RPL rate is 50% in women more than 40 years. And cause may be established only in 20 to 30%. And like Dr. Renu said in the beginning, it is unexplained in the vast majority of cases, maybe 50 to 70%. And we know that for couples, there is extreme distress where RPL is concerned. In doctors, there is extreme frustration. There are many causes, many investigations, but very few specific treatments. So today in my talk, I'll be covering the definition, understanding the various etiologies, and what are the current recommendations and how to evaluate. And I will be taking all my guidelines and my recommendations from this the document, which is the ESHRE Guidelines 2018, which gives us 77 recommendations. I won't be saying all, but what is this answers the question, what is the recommended management of women with RPL based on the best available evidence in literature.
So number one is definition. Like you all have seen earlier, 2 or more spontaneous pregnancy losses before viability. Now, viability in Western countries is defined as 24 weeks. I'm sure in our scenario, it may still be about 28 weeks, but the definition says 24 weeks. Preclinical pregnancy, non-visualized pregnancies or pregnancies of unknown location are also included. Consecutive and non-consecutive are different. Spontaneous or ART pregnancies are all included. Primary and secondary, if they are, if they are, they have a live birth before and then they have a recurrent pregnancy loss, then it is a secondary RPL. If they don't have any live birth, it is primary. And recurrent early pregnancy loss is less than 10 weeks, and recurrent pregnancy loss are all other cases. If you go by this definition, we can understand that ectopics and molar pregnancies are not included. Even implantation failure following a good quality embryo or a blastocyst in ART is not included in this definition. Now, what is the etiology? Etiology broadly I have defined as possible causes, doubtful causes, and unexplained causes. Possible causes are 30 to 50%. Like I said, you may find some cause. Genetics is the vast majority, anatomical, endocrine, and some others like autoimmune, thrombophilias, environment, and I have put in some emerging causes of RPL. So let me quickly cover each one of them. The first is genetic cause. We know that in the human reproduction, it is a highly wasteful and very, very inefficient procedure compared to many other lower vertebrates or many other animals also. It is remarkably inefficient because we know that 70% of human embryos which are formed in vivo are barely ever see the light of the day. They barely ever form a fetus. And spontaneous aneuploidy is extremely common. Now, we are very well aware that in the females, in the X chromosomes, in the egg, aneuploidy is extremely common. And it is mostly the aneuploidies are usually seen in the of the trisomies, monosomies, and polyploidy, etc. is the more, it is the autosomal chromosomes of which you see aneuploidy in the egg. And the frequency, if you look, 90% in specimens that are obtained in losses 0 to 6 weeks, 50% in 8 to 11 weeks, 30% in tissues if it is more than that. And we know that once a heartbeat is evident on ultrasound, the risk of aneuploidy is less than 5% or 10%. But maternal age and its connect to aneuploidy is very well known, understood. So now, what is the recommendation for POC karyotyping? I'll be giving in recommendation in between one by one, whenever the time comes. So is there a recommendation doing karyotyping of the products of conception? Different societies give different recommendations, but ESHRE guidelines and the Green Top guidelines advise that after third or second miscarriage of a POC karyotyping should be done. It is recommended by these societies. And we know that the autosomal trisomies or aneuploidies are common in the egg, but even male factor is now risingly, increasingly understood to be involved with recurrent pregnancy loss. And if you look at genetic cause or the aneuploidies, it is the sex chromosomal aneuploidy which is associated with the male gamete, as against as against the eggs, in which you mostly find the autosomal aneuploidies. So male factor is also very important. Genetic abnormalities in the male gamete is also very important. Single gene defects are not very well associated. So what is the recommendation for parental karyotyping? This is a test we do every day. I mean, whenever we see a case of RPL, it's very easy to do this test, but you'll be surprised that again, different societies vary. ASRM suggests that parental karyotyping should be done, but ESHRE guidelines say that they should be done only in couples who have a very high risk of genetic abnormalities, or if the POC has shown abnormal karyotype or abnormal translocations in any of the karyotypes of which has been done in the POC. So this is not a very overtly recommended test. So we know that there is no treatment for genetic cause. In the end, maybe you can only do genetic counseling to alleviate stress and maybe end up with PGD, gamete donation, which is the last option. Now, anatomic causes. Anatomic causes is very vast, so it's not simply possible to cover them. Congenital uterine anomalies, submucous myoma, cervical incompetence, severe intrauterine synechia, just to name a few. But anatomic causes may be present in as many as 10% and they can be diagnosed. So the recommendation is that to investigate whatever length you go up to, it is acceptable. You can do MRIs, 3D scans, hysteroscopies, HSGs, transvaginal, anything that you can do to detect these abnormalities and subsequently treat them would be justified. Now, congenital uterine anomalies, since it is huge, it's I probably a one-day CME or something like that. I just make two recommendations or 2 pointers which I want as a carry-home message that I would like to give today from my experience, otherwise also. So these are the commonest congenital uterine anomalies we know. And we also know that compared to unselected population, the prevalence of congenital uterine anomalies is almost 2 times or 2.5 times in women with miscarriages. And if you look at the cohort of patients which has both infertility and miscarriages, as much as 25% patients may have congenital uterine anomalies. But reproductive outcome or recurrent pregnancy loss is not always associated. We don't have much evidence to say that this congenital anomaly causes recurrent pregnancy loss. For example, early miscarriages is increased in septums, is increased in bicornuates. Second trimester abortion is certainly increased in septums, unicornuates, bicornuates, and even the dysmorphic uterus. So there is recommendations are not there much, and the diagnosis is not always very simple. But there are 2 situations which I want people to understand. Number one, arcuate uterus is very commonly misdiagnosed as septate uterus, and it is overtreated by hysteroscopic septal resection, which has to be very much controlled. I have myself seen at least a second trimester, one case of spontaneous second trimester rupture of the uterus following TCRS, which was done elsewhere. Septate uterus is another very, very debated topic, whether it needs correction or not, although it has been associated with recurrent pregnancy loss, but whether it should be corrected or not and how to diagnose it is a very, very big question. And whether somebody who has not had infertility or not had recurrent pregnancy loss, should you be treating all septate uterus? So that is a very big issue of debate between reproductive medicine practitioners and reproductive surgery practitioners. And you will be interested to see that there was a very recent publication, 2020, which talked about this aspect, and it said that the weather is getting stormy over hysteroscopic metroplasty for septate uterus, as the long-awaited results of the first randomized controlled trial was published, and they showed that there is lack of any evidence for the effectiveness, and there is potential for harm, and they do not recommend septum resection as a routine procedure in clinical practice. So that is a very, very questionable procedure, and I am not saying do not do septum resection for recurrent pregnancy loss. I am saying don't overdiagnose and don't overtreat, and certainly think 10 times about the evidence that is there when you're treating it routinely in your clinical practice. So that is what these very recent randomized controlled trials tell us. So that was about congenital uterine anomalies and the fact that arcuate uteruses don't need to be treated at all, and septum uteruses need to be diagnosed and treated with care. Now, the third important cause is endocrine causes. This again is a huge chapter, so I have just made some good practice points from the endocrine causes. Well-controlled diabetes and treated thyroid dysfunction is not a risk factor for RPL. 36 to 56% of RPL have PCOS, but PCOS is another ballgame because we simply do not understand why and how and what is the pathophysiology of repeated pregnancy loss that we see in some cases of PCOS. High LH is not a cause of RPL. Women with PCOS who miscarry have high androgen levels. Oligomenorrhea was 10 times more important than any other risk factor for predicting RPL. Insulin resistance is prevalent in RPL. Fasting glucose and insulin ratio is recommended in PCOS with RPL. Metformin, of course, we know that it should be continued for a pretty long time. Hypothyroid and antithyroid antibodies do seem to have a role, and we know that it needs to be treated, but if it is well controlled, it is unlikely to be a cause. Antibodies should be tested because the reproductive age group women have thyroid autoimmunity. So the presence of thyroid antibody is associated with RPL and premature death. The screening for thyroid antibody and treatment with thyroxine when the TSH is more than 2.5 is certainly recommended by most endocrinology bodies. If treated, frequent monitoring is safe and recommended. With thyroid antibodies should be monitored closely and treatment should be initiated if the TSH level is high. PCO, as I said, we seriously do not know what are the causes. Now, then next cause comes is immunological cause. Autoimmune causes are almost 10% of RPL. Almost. Now, autoimmunity, which is the immunity directed against self, we know that. So, systemic lupus erythematosus and antiphospholipid antibody is the most commonly recognized, and we know it well, and it is understood well, and we have good recommendations how to manage antiphospholipid syndrome. It is the commonest autoimmune situation that we see in cases of RPL. The problem is that we don't always diagnose it. For diagnosis, there are plenty of tests. If you look at those hi-fi labs, they give you they give you one this is RPL panel, this is this panel, this is that panel, immunological panel. But the three main antibodies that you should be testing for is only these three, which is ACA, cofactor beta-2 glycoprotein, antiphospholipid antibody, lupus anticoagulant. So ANA is anti-nuclear antibody, that is not indicated. What is the three that I told you is lupus anticoagulant, beta-2 glycoprotein, and anti-cardiolipins. So this is IgG, IgM, IgG, IgM for both, and they should be at more than 99th percentile, and they should be rising or should be same level after repeating it at least once or twice after 2 to 6 weeks. So the clinical criteria where without any tests also you might suspect and diagnose antiphospholipid syndrome is if she has had recurrent losses less than 10 weeks, fetal death more than 10 weeks, if she has history of venous thrombosis and arterial thrombosis. So these are some clinical criteria that might make you suspect antiphospholipid syndrome. And like I mentioned, these are the three tests that should be done only. The other tests that you'll be doing, so many ANA, ALA, this, that, and the other, they are not indicated at all, and they do not help in the management or the diagnosis. These three are enough. Now, treatment is pretty well understood. Low dose aspirin you may give, low molecular weight heparin or the regular heparin, and it should be continued at least up to 34 weeks, and it has shown good results. Now, those were possible causes. Now, let us come to doubtful causes. There are many infections, many anatomic problems, endocrine, alloimmune, environmental, etc. Some recommendations are that there are no evidence that viral or bacterial infections cause RPL. So we don't have any evidence. No convincing evidence against endometriosis. Insufficient data on luteal phase defects. And most anatomical factors, like I mentioned in my previous slide, is an unlikely cause. And one recommendation is performance of torch tests are invariably uninformative and they should not be performed at all. So are the cultures for viruses and bacteria. They are not important at all. So after this cause, which was the doubtful causes, like I mentioned, many endocrine causes, endometriosis, luteal phase, most of the anatomical infections like torch, etc. Now we can next think about emerging causes of RPL. Here I have put three, which probably are a cause, but we need to understand them more and study them a little more. One is male factor, lifestyle factors, and chronic endometritis. If you look at this interesting diagram, you'll see that the responsibility of reproductive failure standard has been understood. 80% is because of a bad egg, 10% is because of problems in the uterus, and maybe 10% in the sperm. But that seems to be rising, by the day, as we are understanding more and more about male factor or sperm factors or the sperm gamete factors and recurrent pregnancy loss. So sperm DNA fragmentation, although we do not have a consistent association between sperm parameter and RPL, many recent studies have suggested that sperm DNA fragmentation, Y chromosome deletions, chromatin integrity, and DNA damage are possible causes that can lead to RPL. And recommendations tell us that there is a moderate association, although we don't have a clear-cut guideline because also we don't have any treatment. These associations these studies may be confirmed that you might do. So in a male factor, it is suggested to assess lifestyle factors like smoking, alcohol, exercise pattern, body weight, and assessing sperm DNA fragmentation. These are considered good practice points, even though they do not have direct evidence and not direct recommendation. From my center also, my people have published multiple papers now in good journals, high impact factor journals, connecting RPL with many male factors. These are some of the studies that we have had. Lifestyle, environment, the fact that we have environmental, the endocrine disrupting agents, we do not probably have any direct association, but we have many suggestive associations like ionizing radiation, organic solvents, alcohol, mercury, lead, which are very often seen as contaminants in the environment and water and soil, as well as caffeine, cigarette smoking, using video display terminals, evidence of anesthetic gases for theater workers. Obesity is another lifestyle factor which is slowly emerging as becoming important factor of possible association with miscarriages, occupational exposure in dentistry and miscarriage. So these are emerging factors which we are understanding that could be that these environmental pollutants and recurrent spontaneous pregnancy losses are associated. Endometritis and recurrent pregnancy loss is another point which is coming up very quickly, and lot of studies are being published. And so maybe a time will come, although we don't have direct recommendation, doing a hysteroscopy and then doing either a visual diagnosis of chronic endometritis or immunohistochemistry tests for endometritis, and then treating it may become standard for managing recurrent pregnancy loss. Inadequate luteal phase, like I said, may be tested, may be supplemented. It is easier to treat it and supplement it without harm, but difficult to substantiate it by evidence. Now, unexplained causes are the major causes now, because if there are no causes that you find after doing a karyotyping for the POC, for the paternal, for the couple, doing all tests for uterine anomalies, doing tests for antiphospholipids, if you do all that and you still don't have any cause, then they are unexplained causes. And some possible reasons for unexplained could be thrombophilias, poor ovarian reserve. This also is now starting to come up as an important cause probably. Hyperhomocystinemia, endometrial factors which are not understood, sperm oocyte factors, and immunological factors which are alloimmune factors. So counseling the couple about the impact of maternal age, smoking, tobacco, alcohol, BMI, stress is probably very important. Of course, vitamin D supplementation, folic acid supplementation are you should initiate from the beginning. Useful investigation probably would be to look for uterine anomalies, number one. Look for some antiphospholipid antibodies and other antibodies, APS syndrome. Look for thyroid function tests and anti-TPO antibodies. These are certainly useful and recommended tests, and sperm DNA fragmentation may be also considered. Following may be considered after risk assessment and for explanatory reasons, since you have to give some explanation to the patient if you're not finding any causes, which is parental karyotyping, POC karyotyping, and hereditary thrombophilias. Very often we find mutations, etc. So you might do these. And treatment choices to improve live birth rate, which is number one, reassure. Prognostication should be based on age and number of pregnancy losses. This is very important because we know that after one pregnancy loss, the chance of live birth is almost 70-80%. After 2 pregnancy loss, the third pregnancy being a live birth, chances are almost 50-60%. After 3 pregnancy loss, we still have maybe a 30-40% chance that the woman will have live birth sometime in the future. So treatment choices, reassure, prognosticate, aspirin, heparin, correction of cavity factors, correction of septate uterus, question mark, cervical encirclage, yes, gamete donation. And this is what I was trying to tell you, the slide which said that if you give it time, many of the women will have live birth in spite of having 2, 3, 4 abortions. So treatment of choices which is not supported by evidence is progesterone, HCG, metroplasty for bicornuate, unicornuate, didelphys, IVIG, intralipase, glucocorticoid, GCSF, mononuclear cells, PRP, IVF, ICSI, ISA, PGS. So these are not supported by evidence. I'm sure some of them have some role in some of our patients. We have to always look and categorize and then decide who can be tried what, under what circumstances. And after explaining to the patient that this could be just under experimental therapy, and then to whichever choices we do. Thank you very much. And I just wanted to end by saying that in 2024, we have the ISAR annual conference in Bhubaneswar, and whoever friends I am not meeting, only meeting in person, hope to see you all soon.
Dr. Sujata, do you have any experience in your practice that if you give such patients, it is also not evidence-based, if the ovulation induction in these patients, then sometimes they do go well. I don't know what is the reason behind it, but I have tried in few of my patients. You don't go with your natural eggs and natural, you should for ovulation induction followed by IUI, then they do well in some. Do you have an experience regarding like this?
No, but then we do, you are absolutely right. After 3 abortions, 2 abortions, you've done all the tests, not found any cause, then we do tell them that if you undergo a stimulated cycle, the possibility is that we will be able to give you some support. Whether it helps or not, we do not know. Give you aspirin, give you progesterone, even before you conceive. So those kind of things might help, but then we don't have any
evidence. Thank you.
Yeah.
Sujata? Hello, Sujata.
Yeah, Maninda.
Will you stay till our panel? Because I want to raise one future pathway thought process which we should be taking for this recurrent pregnancy loss is having designated RPL clinics. With
Certainly, I will be there. I will be online for
so
sure.
That is what we should be having. That is the future.
Today is Sunday, little bit of a family time, but I will be online continuously.
Okay.
Thank you.
But what is your idea of having this designated recurrent pregnancy RPL clinics we should be having in our setup?
I think it is good. It gives.
Because even Ashley recommends it. Even POG recommends it. That it is time we start thinking on these lines. Then it takes us years to make them things possible. We are not able to do midlife clinics so far, but this is another thought process where if we have to evolve in any specialty, we have to do designated work in that specialty.
Yes, certainly.
Thank you. It was very nice, Sujata. And absolutely, I was the one who used to read your newsletter.
Yes, Maninda. Yeah, we always used to discuss it also. I know.
I just wanted to congratulate Dr. Sujata for very, very crisp presentation. And she has touched even the very less important points, means created sort of insight. That is a very important thing. We should be in future, we should discuss that. Or might we say 40 to 50%, we don't know any cause. But maybe after 5-10 years, that will decrease to about 20%. Because some of the causes may like that might be endometritis or may come out to be leading cause, including the DNA fragmentation. So we should look into that before saying that it is an unknown cause for the recurrent pregnancy loss. It is a very good. So I just congratulate again for this presentation, Dr. Sujata.
Sujata, thanks for revising all the factors which we all and enlightening our knowledge. But one thing I would like to add, we practice in very rural area where people have limited access to all the investigation, high finders. But it's very traumatic for the patient, mentally, physically, economically, for the patient, her family, and for us also, treating doctor. And we declare immediately after doing TVS or TS, oh, no cardiac activity. And you see the tears rolling down her eyes. And then the affordability of the patient. So what we used in rural practice, I have seen out of my 35 years practice, I heard some people in conferences also, because I used to attend many, that pregnancy is when you don't find any cause, like mote causes, whatever you have enumerated, besides the karyotyping, then think of the simple, it is immunogenic, pregnancy is immunogenic, and start giving low dose of steroid, which we had the impression should not be given in early pregnancy because it causes maybe cataract or something else. So I started giving, telling you the truth, low dose 2.5 milligrams steroids and taking care of the infections, vaginal infections, which used to be the major factor after excluding apparently what we could see on sonography, on general thyroid, everything. And then used to treat patients, whatever you put after torch test, we give robamycin, very safe, started giving them robamycin, and then Zovirax, antiviral, acyclovir, and the patients rarely reached well. Though it is not like ethicated, you should have all the list, but still it worked wonder. And thank you for enumerating everything and enriching us again for wonderful presentation. Thank you.
Thank you.
Thanks, Dr. Chanchal, for your nice inputs. Now I would like to invite Dr. Anita Narula to introduce Dr. Isha.
Renowned pathologist of Rohtak, and she's very active participant. Though she's a pathologist, she takes parts in each and every webinar, CME, whatever is done in the Haryana. At present also, I think she's attending something in SGT, and she's very knowledgeable, and we are grateful to you are chairing a session here, ma'am. Welcome you.
Very right.
Okay. Thanks, Dr. Rakhee. Thanks, Dr. Rakhee. I think now we can proceed with the introduction of Dr. Isha.
Yeah. Thank you, Dr. Rakhee, for a kind introduction. Dr. Isha has done MBBS and MD from Lady Harding Medical College, and then she did SRship from AIIMS. And then she did fellowship in fetal medicine and diploma in clinical and fetal genetics. And she has also done fellowship in musculoskeletal ultrasound. Now she is chief of fetal medicine and genetics and women imaging at Narula Diagnostic Centers Rohtak. And now she is doing regularly antenatal ultrasound, fetal echos, fetal MRIs, amniocentesis, and women's imaging. And she has delivered many talks at national and the international forums. And one thing additional I would like to add, she is a sports person too. And she was in AIIMS cricket team and got best player award in AIIMS cricket team. And now recently she represented IMA Haryana and in badminton. And one more, she represented Lady Harding in a fashion show held at AIIMS. So she got best face of the year that time, and she was doing undergraduation. So this is all about Isha. Thank you very much. Now,
yeah, Thank you, ma'am, for such a kind introduction. And I would like to thank Dr. Rakhee Malhotra for giving me an opportunity to present on this platform in front of such an august gathering. Today, I'll be discussing about genetics in recurrent pregnancy loss. Dr. Sujata has summed up the entire genetics guidelines in her talk, but I'll be discussing them again. So genetics of recurrent pregnancy loss. For the busy gynecologist and IVF practitioner, genetics is usually viewed as a complex nuisance or a complex thing that interferes with their busy clinical practice and management, and it takes a lot of time to understand the basics and the pathologies of the genetics, and gives them little time to focus on their more important issues like conducting deliveries or surgeries, etc. So just to make things simpler, the genetics as a whole is very vast, but what we need to know is very little out of those things. So as we all know, the human journey begins with the development of an ovum and a sperm, and when they undergo fertilization, a zygote develops. Once a sperm has come into contact with the ovum, it blocks the entry of the other sperms and does not allow them to undergo fertilization. Then the zygote, then it travels the fallopian tube, goes into the uterus, undergoes implantation, and then maintenance of pregnancy is there. So all these processes is just a wonder of nature, and it requires many of the immunological, the vascular factors to continue the pregnancy till the end. And if there is any pathology or any genetic abnormality that occurs during this process, especially in the first trimester till the process of implantation and the embryonal development, it results in the early pregnancy loss. So 20% of all conceptions, they abort before 20 weeks and mostly before 12 weeks. And 75% of miscarriages, they are due to the failure of implantation and initial vascularization. And majorly, as we know, that genetic factors account for are responsible for most of these cases. Even if we do not know the exact genetic factor which is responsible for it, mainly it is the genetic etiology. Now, as ma'am has already covered, that pregnancy losses are usually early pregnancy loss. We define till 24 weeks of gestation, and they can be first trimester or the early second trimester loss or the biochemical pregnancy loss. So how many losses are required to diagnose the recurrent pregnancy loss? Already told by Dr. Sujata that various societies have various definitions of defining the recurrent pregnancy loss. So ASHRAE and ASRM defines 2 or more failed clinical pregnancies as the recurrent pregnancy loss, whereas RCOG or the says loss of 3 or more consecutive pregnancies, but then RCOG includes the biochemical pregnancies as well, which was not included by ASHRAE or ASRM. Now, prevalence of recurrent pregnancy loss is 1 to 2% if we consider more than 2 pregnancy losses as recurrent pregnancy losses. So again, what do you count as a pregnancy loss? It is mainly the clinical pregnancy loss which we count as a pregnancy loss. Clinical means whether it is ultrasound evidence of pregnancy should be there, or there should be a histological confirmation of pregnancy. Only then we say it as a clinical pregnancy loss. So as we can see that almost 60% of the pregnancies undergo preclinical pregnancy loss. That is, even before the woman comes to know that she is pregnant, the pregnancy loss has already occurred. Only 30% of pregnancies progress to the live birth, and 10% are the clinical pregnancy losses which we encounter. No, the main etiologies have been already covered, but again to describe that 10 to 15% are anatomic factors, 20% are autoimmune in nature, mainly because of the Apla syndrome. Then we have the endocrine factors like thyroid, prolactin, diabetes, infections, and 2 to 5% accounts for the genetic factors. Majority of the pregnancy losses are unexplained. Probably they are unexplained because because I think majority are the genetic in nature, and a lot of genetic work has not been done to explain these unexplained causes. So once we start doing the genetic workup of these patients, then most of the unexplained will fall into the category of the explained causes. So now genetics in RPL will be, as we progress through this talk, we'll discuss about the role of genetics in the testing of the couple, in the testing of the product of conceptions, and just a few slides about hereditary role of genetics in hereditary thrombophilia, sperm DNA fragmentation, and a new study which has come up in 2020 after the HRA protocol. I'll be discussing a few points about that also. So most of the chromosomal anomalies, they start right from the preconception periods and are prevalent in adult till the adulthood. Majority of the chromosomal anomalies, which are lethal chromosomal anomalies, account for first trimester abortions. Almost 50% of all first trimester abortions are genetic in nature. And as a child is born, the rate of chromosomal abnormality is 1:116 live births. Until adulthood, we can see that adults can also have a genetic abnormality in the form of balanced translocation, which ranges from 0.5 to 1%. They can be carriers and still clinically normal. So now the question arises whether we should do karyotyping for all cases of recurrent pregnancy loss couples, or we should do karyotyping for patients with suspicious or unexplained recurrent pregnancy loss. Now the different societies have different views. The various chromosomal abnormality, the ASRM society says that we should do the karyotyping for all cases of all couples of recurrent pregnancy loss. And the reason why it says so is that the various chromosomal abnormalities which occurs in couples are the balanced reciprocal translocations, the Robertsonian translocation, mosaicism, inversion, microdeletions, and almost 46% are other chromosomal variants. Now, why do we need to know that whether the parent couple has a balanced reciprocal translocation, or it has a Robertsonian translocation, or there is an inversion? Because the prognosis is based on the parental karyotype. As we can see that if the parent's karyotype has a reciprocal translocation, there are 50 to 70% chances of recurrence in the subsequent pregnancy, and there are 50 to 70% chances of miscarriage. Whereas for Robertsonian translocation, it is 30 to 50%, and for inversion, it is around 30%. So ASRM, based on these things, ASRM recommends parental karyotype analysis for the balanced reciprocal translocation to know the reciprocal translocation and thereby counseling the parents that whether the recurrence rate will be there in the next pregnancy or not. Whereas HRA recommends testing only in couples at an increased risk. How do we say that which couples are at an increased risk? If there is a history of a previous child with congenital abnormality, or if the couple has an offspring with an unbalanced chromosomal translocation, or the product of conception is showing an unbalanced translocation, then HRA recommends testing. And RCOG advises parental karyotype only when an unbalanced structural chromosomal translocation is there in the product of conception. But a study was conducted in 2018, which shows that parental karyotyping for all RPL couples is simply not effective, and there is no overall difference in live birth rate when comparing with the pre-implantation genetic testing to natural conception in those cases. It says that even if we have diagnosed a balanced translocation in a couple, we are not able to offer any treatment to the couple. 60% of cases will undergo expectant management, and even if we offer the pre-implantation genetic testing, and we see that how many patients of pre-implantation genetic testing has given live birth versus the patient who are undergoing natural conception, the live birth rate was similar in both the groups, that is of the PGT testing to the natural conception. So that is why they say that there is no role for parental karyotyping, except for that it will give them a reason that it will give them an explanation for their pregnancy loss. So this was about the parental karyotyping. The next is the karyotyping of the product of conception. Now, would you recommend regular genetic analysis or genetic analysis of all abortus? And if yes, for all abortus, then why? And if no, then why? So as we all know that the 90% of the embryos who have the genetic abnormalities, they undergo the pregnancy loss. And as the gestational age of the fetus increases, the chances of the fetus having a chromosomal anomaly responsible for the pregnancy loss is less. So around 20 weeks, if the fetus is undergoing the demise, then there are only 12% chances of it being chromosomal in origin, as compared to the pre-implantation stage, when there are 90% of chances of it being chromosomal in origin. So the various chromosomal pathologies that we have found in the conceptus are, the most common are the aneuploidies. out of which, as ma'am has emphasized, the trisomies are the most common. It can range from autosomal trisomies, multiple trisomies, autosomal monosomies, sex chromosome monosomies. Then it can be a triploidy, that is the entire haploid chromosome, the set of haploid chromosome is extra, or tetraploidy. And then there can be segmental deletions, duplications, and single gene disorders. Single gene disorders are responsible for less number of causes of early pregnancy loss, probably because they have not been studied into much detail. It is not that they are not present, the mutations are not there. It is probably because they are not studied in much detail. That is why they account for less number of causes for recurrent pregnancy losses. Now, as maternal age increases, risk of aneuploidy increases, and the background risk of having 3 miscarriages for women less than 25 years is 0.13%, whereas when the woman age increases more than 40 years, it becomes almost 13%. That is 100 times more likely. So what is the importance of testing of these abnormalities in the product of conception? The importance is that we should rule out the genetic cause of miscarriage. Even though we are not able to offer any much treatment to the patient, at least we are able to find out the cause of the miscarriage, and we are able to provide them the risk of recurrence, whether there is future risk is there or not. If we are able to find an anomaly which is sporadic in nature, the couple can be reassured that it will not recur in the next pregnancy. And if it is associated with an unbalanced translocation, or if it is associated with parental chromosomal abnormality, then the subsequent risk in next pregnancy is increased. Now, what are the methods for testing the product of conception? The anomalies I have already covered. What anomalies do we test in product of conception? The numerical anomalies and the structural anomalies. The methods are the karyotyping, FISH, and the microarray. And with the latest advances, still in research purpose, we have the whole exome sequencing, which is still in research purpose for the recurrent pregnancy loss, as it is expensive. Now, this is an image just showing the anomalies which can occur. This is a diagram of an insertion in which a part of the chromosome segment of the chromosome from one chromosome gets inserted into the other chromosome. We have an image of insertion, duplication, inversion. So just to explain the different, when do we do karyotyping, when do we do the chromosomal microarray, when do we do FISH, and when do we do the whole exome sequencing, we can imagine our genome as a book. So our whole genome is a book, and each book has multiple chapters. So each chapter can be compared with a chromosome. Like we have 23 pairs of chromosomes in our body. Similarly, we can assume that book has 23 chapters. So each chapter of book can be compared with the chromosome. If we want to look in any anomaly pertaining to the number of the chromosomes, whether it has increased or decreased, then we majorly do the karyotyping. And every chapter has certain pages in it. So each page can be compared to the gene. If we want to look at the anomalies of the sentences or the page or the gene, then we'll need to look into the chromosomal microarray. That is, we need to look whether there is a deletion in the chromosome, whether there is a duplication in the chromosome, which is out of the limit of the karyotype. We do the chromosomal microarray. Now we know that each gene is made up of the nucleotides. We have 4 nucleotides, A, G, T, and C. And these nucleotide base pair, they form together the genes. So if we want to go to the nucleotide level, single gene mutation, we say, then we need to do gene sequencing, or in which we do the whole exome sequencing or the next generation sequencing. So this is how we decide whether we have to do the karyotyping or the chromosomal microarray or the gene sequencing. So initially the ASRM advocated the use of karyotyping in the product of conception. In the karyotyping, the chromosomes are arranged from chromosome number 1 till chromosome 22 in the order, and based on the G banding. And we can look at them in the low power or high power and by the cytovision software karyogram, and can find out the anomaly in the number or a large number, if there is a large duplication or a deletion. But the limitation of the karyotype is that it cannot detect small micro deletions and micro inversions. So that is the limitation of karyotype. Also, the karyotype needs time to grow, because in the karyotype we are making the cells to grow. So it takes almost around 14 days for the cells to grow. So the reporting time increases. The patient has to wait for 14 days. And third, if the tissue is non-viable, then it will give a non-conclusive result. And culture failure rate for fresh tissue is also 14%. And as emphasized, that we cannot describe the microscopic deletions or duplications. The next is the fluorescence in situ hybridization. The advantage of fluorescence in situ hybridization is that we get the result in 2 to 3 days. What we do in fluorescence in situ hybridization is, if we already know the gene to be, the sequence to be seen, or the area of concern is known to us, then we can use the fluorescence in situ hybridization. Commercially available probes are there for each sequence to be mapped. So whichever sequence we need to map, we take a probe for that and we label it under, tag it with the fluorescent dye and look under the microscope for that. So commonly we look in fish for chromosome 13, chromosome 21, chromosome 18, and for the sex chromosome. And also if we are looking for any particular anomaly, we can take the probe and band it. And the results are available in 2 to 3 days. So this is an image of trisomy 21, which was detected in the product of conception sample consistent with the Down syndrome. But the best and recommended by the societies are the chromosomal microarray analysis in the product of conception. Why? Because it is able to detect the small amount of microdeletions and duplications also in the chromosome. It can detect the copy number variations, which can be missed by the karyotyping. So this is a table again summarizing the things which I have already told, that the resolution of karyotyping is less. It can detect if the anomaly is in the range of 10 million base pairs or more than that, then only it can detect the anomaly. Whereas microarray can detect as less as 1 million base pairs. The only limitation of microarray is that it cannot tell us about the balance translocation. That is why in the parents, we prefer the karyotyping, whereas in the product of conception, we prefer the microarray. So ASRM does not recommend routine use of the product of conception karyotyping or microarray in the routine testing. ASHRAE says that genetic analysis is not routinely recommended, but it could be performed for explanatory purposes. That is, it is not for treatment purpose, but for explaining the cause of miscarriage to the patient, we can use do the genetic analysis of the pregnancy tissue. And if at all we have to do the genetic analysis of pregnancy tissue, then we have to do the microarray and not the karyotyping. Then, as I told, there was a study published in 2018 in the Human Reproduction Journal by Popescu. It says that if we combine the 24 chromosome microarray of miscarriage to the workup of the ASRM workup of the recurrent pregnancy loss, then we'll be able to assign cause in over 90% of the patients, as 50% when we do not consider the product of analysis microarray. Then the next topic, which was about the single gene, whole gene sequencing, in which we are able to detect the single gene disorders also. It is still in research purpose and not available for routine for the commercial use of the recurrent pregnancy loss. The advantage of the detection of the single gene disorders is that, as already mentioned, when the fetus is being developed, the immunological processes are going on, the vascular processes are going on, lot of cell division is going on. So if any mutation occurs during that process, any mutation even in the single nucleotide occurs during that process, it can lead to the early pregnancy loss, and it will neither be picked up in karyotyping nor be picked up in the chromosomal microarray. So that is the advantage of doing the whole exome sequencing in the product of conception. But again, since it is very expensive and will not be able to offer any treatment to the patient, it is still not recommended for routine use. So this is a study which was done in 2016. It again emphasizes the same thing, that there was a couple with the history of 2 miscarriages. The entire RPL workup was negative, including the chromosomal microarray of the previous 2 abortuses. So the third time the patient underwent, the couple went the whole exome sequencing, trio whole exome sequencing. By trio, we mean that the whole exome sequencing was done for the father, mother, and for the product of conception. And in that, a mutation was seen in the DYNC2H1 gene, which was responsible to be involved in cilia biogenesis and has been associated with fetal lethality. that is asphyxiating thoracic dystrophy or short rib polydactyly syndrome in humans. But it is so lethal that even even before the proper development of a fetus, the pregnancy loss occurs in the embryonal stages only. And since the whole exome sequencing is not routinely done in these couples, they are labeled as unexplained causes of recurrent pregnancy loss. So just a slide about the thrombophilia screening in women with RPL. Dr. Sujata has already told that acquired APLA syndrome we screen in a non-pregnant woman who is coming with a history of recurrent miscarriage loss. But the hereditary for hereditary causes of thrombophilia, the HRA does not recommend the routine screening, but it says that we can screen for hereditary thrombophilias only if there is a high risk factor for the thrombophilia being present. That is, if there is a family member with hereditary thrombophilia or there is a previous history of venous thromboembolism. Again, the male factor infertility, we, apart from taking the routine clinical history, the examination and doing the semen analysis, we can look at the sperm DNA fragmentation assay to look for the sperm DNA fragmentation index, which is done by the FISH method. Now, the higher the sperm DNA fragmentation index, there are higher chances of RPL. So apart from female factor infertility, we can also look at the genetics of the male factor infertility. But the only disadvantage of looking for the sperm DNA fragmentation index is that we cannot offer again a definitive treatment to the patient. So routinely American Society does not recommend use of the sperm DNA fragmentation index, but HRA says that it can be done in couples for explanatory purpose based on indirect evidence. So till now, everybody is following the HRA guidelines, which were published in the year 2017. Another paper was published by Ralph S. Papas in the Journal of Current Opinion and Obstetrics Gynecology in 2020, which provides a new algorithm for the evaluation of the recurrent pregnancy loss. It says that the initial, the recent findings, it says international societies have published different recommendations for the evaluation of RPL, and they consider it appropriate to initiate an evaluation after 2 or 3 clinical miscarriages. On the contrary, the clinician who follows these guidelines will only be able to offer a possible explanation to fewer than half of the couples being evaluated. But if we add genetic testing of miscarriage using 24 chromosomal microarray, we can provide an explanation in more than 90% of the cases. So this study says that apart from the routine ASRM screening, if we add the product of conception testing chromosomal microarray to our routine testing, rather than 50%, we'll be able to attribute the cause for the recurrent pregnancy loss in almost 90% of the cases. So this was the ASRM guideline for workup of RPL, in which we look at the anatomic factors, the endocrine factors, the autoimmune factors, lifestyle of the patient, and the routine genetic karyotyping of the parents. So if we just look at the ASRM workup and we do not do any product of conception microarray, then we can see the abnormality in 42.9% of the cases only, and rest 58% goes unexplained. If we only do the product of conception chromosomal microarray, then we can find out the abnormality in 60% of the cases, and 40% of the cases will still not be able to figure out the cause. But if we combine the ASRM RPL workup and the product of conception chromosomal microarray, we can attribute the cause of the recurrent pregnancy loss in almost 90% of the cases. So this is a table which summarizes the guidelines by the RCOG, ASRM, and HRA. So based for the parental karyotyping, HRA says it is conditional only after individual risk assessment. But the latest publication in 2020 says that the parental karyotyping is not recommended unless the chromosomal microarray of the product of conception reveals unbalanced translocation. And for the product of conception, it says, the HRA says that it is conditional only for the explanatory purpose or when the high risk is there. But this proposed guidelines says that we should use it for every product of conception after 2 miscarriages. So it has proposed this algorithm that after 2nd miscarriage, we should screen the woman for weight extremes, alcohol, smoking, for the uterine anomalies, for antiphospholipid syndrome, for endocrine testing for TSH, TPO, prolactin, and based on the cause, we should start the treatment. Apart from this, we should do the cytogenetic analysis of the product of conception. If the product of conception shows aneuploidy, which is the most common chromosomal anomaly in the product of conception, we do nothing else because mostly aneuploidies are sporadic in nature. So no further testing is done and we carry out the expectant management in the further pregnancies. If the product of conception comes out to be euploid, that is the product of conception is normal, then we look at the other causes of the recurrent pregnancy loss and manage accordingly. If other causes are also negative of the recurrent pregnancy loss, then it goes into the category of the unexplained cases. And then we go, and for these unexplained cases, which will account only for 8% of the cases, we can do the further advanced testing of the patients if the patient wants. We can consider hereditary thrombophilia testing for them, sperm DNA fragmentation testing, parental karyotyping, chronic endometritis testing, only in the unexplained cases. And if the product of conception shows unbalanced translocation or inversion, then we do the parental karyotyping. So parental karyotyping is not routinely recommended. It is only done when the fetus or the product of conception shows unbalanced translocation or inversion. And we offer genetic counseling to the patient for expectant management versus the PGT-SR. So to conclude, genetic factors account for around 5% cases of recurrent pregnancy loss. And in spite of recurrent pregnancy loss, couples have 50 to 60% chances of a good outcome in the subsequent pregnancies. Chromosomal etiology is the most important cause for recurrent pregnancy loss, especially in the early pregnancies. And couple karyotype and product of conception microarray are the basic genetic testing to guide the management. And single gene etiology and whole exome sequencing is newer upcoming with limited literature, but it requires detailed pre-test genetic counseling. So in unraveling the mysteries of RPL, I say we have come a long way. We'll have a long way to go.
I just wanted to know, Dr. Shah, what is the cost of karyotyping of products and the parental karyotyping?
Ma'am, for parental karyotyping, it is not expensive. It is around 3,500 per person. It is 3,500.
As a couple, it is 3,500.
No, one person.
No, for one person. For one person.
One person.
Okay.
Here, mark price for the patients is 5,000, but doctors
Product
I'm not able to.
and product karyotyping.
That's
Ma'am, for product karyotyping,
CMA, that is costly. Micro
yes,
array.
CMA is costly. Yes, ma'am. CMA is costly.
it is about 12,000, I think.
Yes, ma'am. Around 12,000.
Yeah, Dr. Isha, I have it's a very nice and elusive talk, detailed one. And I just have one question. If NIPT is normal, then do we need to send the POC for further microarray?
Yes, ma'am. Even because NIPT, as we traditionally know that NIPT is testing only the fetal, looking at the fetal circulating cells in the maternal circulation. So first, we need a good number of fetal cells in the maternal circulation for a report. And if, other thing is that it is looking at the trisomy 21, 18, 13, and the sex chromosome anomaly. It is not looking at any other anomaly. It is not looking at microdeletions or duplications. So even if NIPT is normal, there are still high chances that the product of conception may show some microdeletions or duplication. Yeah. So that is why even if NIPT is normal, we need to subject the product of conception to microarray.
Vote of thanks to Dr. Isha, Dr. Anita. Are you there, Dr. Anita? Please sum up her talk and say vote of thanks so that we can.
Yeah, it is very nice and elusive talk and in a very informative.
Sorry, ma'am, I
It's okay.
And one thing I would like to, what she said, just to sum up, that the karyotyping of POC is now not of much use. It is a microarray which should be done for POCs, and the sample for POC is sent in saline. And one thing if Isha can hear me,
yes,
if
ma'am.
Couple has balanced translocation, what is to be done?
PGT.
if the couple has previously 60% of couple can undergo expectant management. There are 60% chances that the healthy baby will be delivered, and already mentioned that there are not much difference between the live again the voice is echoing. Not much difference between the live birth
Yeah,
of
it's not
PGT and the expectant management. So first of all, we have to offer expectant management, and we can counsel the patient about the PGT or about these the ovum donor or the sperm donor, depending upon the cause responsible for the partner responsible for the balanced translocation. And ma'am, that the sample we have to send in the normal saline.
Is there any role of this genetics in late RPL?
Not much. The genetics is mainly responsible for early pregnancy losses. As the gestational age advances, the genetics take a step back, and we have more of the thrombophilias and the immunological factors or the endocrine factors responsible. Because genetic abnormalities are mostly lethal in nature. So because of the lethality, the fetus aborts early.
If the patient has a repeated blighted ovum, then do you need to send for the POCs?
I'm not able.
If the patient has repeated blighted ovum, then do we need to send the POCs for genetic testing?
Yes, for the yes, again the microarray needs to be done for the repeated blighted ovum to find out the cause for the pregnancy loss.
Thank you. Thank you, Dr. Isha. Thank you very much. So we
can. Thank you, Dr. Anita, for your final word. I would like to sum up a bit, Dr. Isha, for a common gynecologist. I think it is very good to send a take-home message that if you are doing DNC on a patient with a history of 2 or more recurrent abortions, you must preserve POC in normal saline and send for testing. This is for a common gynecologist.
And we have we have already, ma'am, pre-made containers are there in this, the normal saline plus gentamicin is there, which we can usually preserve in normal saline plus gentamicin is routinely recommended for.
We put some antibiotic because I think the traveling time also should be as minimum as possible. And if we are postponing it, we can keep it in the refrigerator.
Yes.
So that is more important. So the thing is, second thing is, if POC is not available, supposing patients abort somewhere else at home, coming late, so then we have to resort to parental karyotyping because we don't have any other alternate. Then we have to do parental karyotyping, I suppose. Am I right?
Yes, ma'am.
If POC not available, patient coming late, then parental karyotyping is advisable, because at least some of the causes will be excluded. So, I mean, we are able in a position to satisfy the patient, and many times we can have some reports. And of course, depending upon the report, instead of yourself coming to a conclusion, we must discuss the case with the genetic specialist. That is very important. What to do the next?
Proper genetic counseling is required.
That is very important. I mean, everybody cannot be expert in everything. So we should know limitations that we send and then discuss with them. So I hope, Dr. Isha, in future we are sending you and you will be able to discuss with us and respond to our calls.
Yes, ma'am. Yes, ma'am.
Thank you very much for your nice presentation, and the rest we'll be discussing in the panel. So now I think it's time to start the session 2, and I would like Dr. Rakhee Malhotra, my sweet secretary, to take over the charge and start the second session.
Thank you, ma'am. I'll invite my next session chairperson. So I first introduce Professor Dr. Dipika Deka. She is a consultant fetal medicine and genetics in Cloudline Hospital, Gurugram. Welcome you, ma'am, for this, and it's a great honor to have you here, and thank you for sparing your time. And she's the president of Delhi Gynecologist Forum in Dwarka, and she has so many publications and Foxy Awards, and she's a professor and unit head of the Chief Medical Maternal Fetus and AIMS, and she is Vice Chancellor, SS University of Health Science, Government of Assam. So she will be a great boost to us for our panel discussions and as an expert, and I hope so she will solve our so many queries. Welcome, ma'am. Next chairperson of the session too is Dr. Jitendra Chadha. She's a very busy gynecologist. She is a consultant at Research Center, Chadha Hospital, Yamuna, Haryana. It's hard to contact her because she's very, very busy gynecologist, and I hope so from her so much experience, she will be very helpful to guide us through these controversies of how to manage a recurrent pregnancy loss. Welcome you, ma'am. And I request my chairpersons to introduce moderators of panel 1.
Good evening, dear friends. With the background knowledge of recurrent pregnancy loss and role of genetics in RPL, now we have a very interesting panel discussion of applying that knowledge and application of that knowledge to different case scenarios. And for that, I will be inviting the two moderators, Dr. Maninda Rahuja ma'am and Dr. Manisha Mehta. Please put the CV of Dr. Maninda Rahuja ma'am. Dr. Maninda Rahuja ma'am, she is President of Society of Meaningful Life Management. She is Director, Ahuja Healthcare, Dental and Infertility Center, and she has got 40 years of dedicated work for women working from adolescence to menopause. She has been Vice President FOXY 2015 to 2014. Rest of the things, she has got a lot of publications, and she is a very active member of various societies. I welcome you, ma'am, for this panel discussion as a moderator, and Dr. Manisha Mehta. Dr. Manisha Mehta, a very nice, very chirpy colleague of ours from she's the director at IVF Center, Sujata, and she was the past secretary, Haryana ISAR. Welcome, Manisha, and now you can proceed on with the panel discussion with your panelist introduction.
Good evening, everybody. I think thanks for the nice introduction. Chairperson, thanks to Renu, Dr. Rakhee Malhotra, organizers of ISAR Haryana. I was one of the founder members of the ISAR Haryana, so I'm closely related to it. So, and thanks to Dr. Nandita, Palshetkar for making it possible, and Dr. Sujata also for being one of the coordinators here. Thanks to our speakers who have given such wonderful talks on genetics, and Dr. Sujata also for the recurrent pregnancy loss, highlighting it. And we'll be just, I think, going through again the same process, but making it really understandable what we have to do in the clinical practice. So should I share my screen? So thank you again, Haryana chapter of ISAR, for giving us this opportunity to talk on a very, very important topic. And I must first of all welcome my co-moderator, Dr. Manisha Mehta, who is a very active and enthusiastic coordinator and responsible for the introduction of many cases which she wanted to discuss. And we have as our panelists, Dr. Savita Rani Singhal, who is a senior professor and unit head of PGIMS Rohtak, Haryana, and more than 33 years of teaching experience, and convener of Hargobind, Vice President Rohtak FOXY, awarded international fellowship by ICOG at New York, and member of editorial board and reviewer for international journal and field of interest is adolescent gynecology and oncology. No, I don't have to go. Okay. My next panelist is Dr. Rubina K.D. Singh, as the founder of the Grace Fertility Center and Fellowship in Fertility Specialist. Dr. Neelam Bhisham, who is a senior consultant OB/GYN practicing since last 30 years. She is going to contribute a lot to this panel, as she is a life member of ISAR, IMS, IFS, and special interest in infertility ultrasound. Lakshmi Goel, who is from our Faridabad itself, and IVF consultant at Cloud9 now, and a fellowship reproductive medicine, Aspire she is. And then we have Dr. Pooja Dhir Bhaina. She is the clinical director at Sonakshi IVF, ISAR and Rohtak, past consultant at Nova IVF, ISAR, and fellowship in infertility and ART and Nova Ahmedabad. and successful advanced training in embryology at BACC Bangalore in 2012, and post-MD 12 years of experience. So she's going to contribute a lot to this panel, I think. And welcome to Dr. Dipika Agarwal, who is from Rishiram Hospital, Yamunanagar. And she is registration Haryana Medical Council, membership of many organizations like FOXY, IMS, IMA, Hargobin, and area of interest are high-risk obstetrics and infertility. So now we come to the topic, introduction, the recurrent pregnancy loss. Now, recurrent pregnancy loss is a very, very negative effect on the couples. It's not only the wife, it's the husband also which is involved. And it's not only the couple, it's the family is also involved, and there are the social impacts of also this thing. So what is the main thing? This RPL is not going to kill the patients, but what is going to give them is worse than the death even. Because each pregnancy loss, like the woman and the husband, they feel so dejected. So what is most important in this panel is the counseling of the couples. So that is where we will be moving forward, because we have to do the proper counseling to give them hope. Because as our previous speakers also said, 75% of the causes will be unexplained infertility, which will conceive anyway. So till the time we can give them some help, some hope, I think we have to give them at least a peace of mind and a positive. That is very important. Prevalence of RPL, they said it's not easy to tell, because the numerator experience who is experiencing RPL and the denominator women at risk of RPL are all at the age of fertile age and who try to get pregnant are difficult to obtain those numbers. But depending upon different studies and everything, pregnancy loss is 5 to 15%, but recurrent pregnancy loss is less, it's 1 to 2%. So if we think we have all the answers, then we haven't asked enough questions. Will it happen again? How it can be avoided? Why did it happen? Why me? Could it have been avoided? So lots of dilemmas are there in this. Yes. So when a thing ceases to be a topic of interest, it ceases to be a subject of controversy, it ceases to be a subject of interest also. So, but RPL is interesting and controversial. Lots of controversies are there. So at the end of the this panel, let's see what controversies we can come out of it. So first case is maze of RPL, real life situation. The patient Sunita, 28 years female, married for 3 years, not able to conceive, and she comes to you. UPT is mildly positive, faint line is there. You do the beta HCG, it's 60 international units, and then after 8 days you do it, gestation sac is not seen, and she starts bleeding on day 40. What went wrong? What can be done? I think the answers are already given, but our panelists will be given. After 3 months, she visits again, and this time gestation sac seen, beta HCG 200, and she aborts after 2 weeks. So when we start defining RPL, this question goes to Dr. Neelam Bisham, please.
Thank you, ma'am, for giving me the opportunity. So now how we define recurrent pregnancy loss. So basically the pregnancy loss is defined as a spontaneous demise of a pregnancy before the fetus reaches the viability. The term therefore includes all the pregnancy losses before 24 weeks of gestation. So because with the coming, with the newer concepts and the neonatal care, after 24 weeks up to 24 to 28, yes, the the babies are given good care and they are viable, but before 24 weeks it is very difficult. So we mark it as a 24 weeks borderline. So what is the definition? We divide it into two, primary recurrent pregnancy loss and secondary recurrent pregnancy loss. That is, in primary, there is no ongoing pregnancy beyond 24 weeks of gestation, and in secondary, yes, patient has had either a live birth or a abortion after miscarriage after 24 weeks of gestation. That is primary and secondary pregnancy loss. Then coming to the confirmation of pregnancy, how do we confirm that she is pregnant? So biochemical pregnancy losses are like we do serum beta HCG or urine beta HCG. When it is positive, then we say it is a biochemical pregnancy is there. If it is not visualized, in the non-visualized pregnancy losses after gestation week of 6 weeks are included, where an ultrasound examination was done later after the patient has aborted or it has after heavy bleeding, there is no gestational sac seen in the ultrasound, but that is called the biochemical pregnancy losses. So how do we, in these cases, the ectopic and molar pregnancies should not be included in the definition. Implantation failure is also excluded from the definition. That is where no gestational sac is seen, or pregnancy losses both after spontaneous conception and after ART treatment should be included in the definition. So it can be early pregnancy loss, where loss of 2 or more pregnancies before 10 weeks of gestation age is there, that is included, that is called early pregnancy loss, and from 10 weeks to 24 weeks, that is late pregnancy loss. So there are different definitions as per the Royal College of Obstetricians and Gynecologists. There they say that is the 3 or more consecutive pregnancy losses are considered as a recurrent pregnancy loss, whereas American Society of Reproductive Medicine, they say it has to be confirmed by ultrasound or the histologically, it should be confirmed, then only it is called the recurrent pregnancy loss. Although the USHR's recommendation, the use of recurrent pregnancy loss is described repeated pregnancy loss after 2 or more pregnancies. Whereas there is it should be confirmed intrauterine miscarriages are there. So the terms spontaneous abortion, chemical abortion, and blighted ovum are ambiguous, and these should be avoided in this. That is how we define the recurrent pregnancy loss.
Yes, thank you very much. I think she has very clarified it. We have to turn, I think for India scenario, we will all agree that we will agree with that, go with the HRA, and after 2 pregnancy losses, I think we should start investigating. But even at 1 pregnancy, when the patient has come for the first abortion only, and we have confirmed the pregnancy, I think some of the tests we are doing in all the antenatal patients, which can be done in these cases. Because why it's important to terminate? Because it's either 1, 2 loss or 3 loss. That is very important when we start doing the further investigation. That is very, because the psychological impact on the partners, that is very, very important. So we have to tell them proper counseling can be done. They have to be made available, understand what is going wrong with their body, at what level. So actually, I show them the models and show them how the pregnancy is taking up and how these are. And normally we used to think that it's stressful for the female only. No, it's a negative life event for the males also, because now we know that the male factors is also as important as the female factor. So when we are looking to, most of the time we should be doing their counseling together. And counseling is important because we have to make a management plan. So although an evidence-based treatment is lacking for RPL, couples value a plan for the next pregnancy. So that is why when I was talking about, in the later on also we'll be talking about dedicated RPL clinics perhaps. Because before trying to conceive, again next time they will be asking you, clinician attempt to find an explanation why it has happened. What are my percentage of having a normal pregnancy? What are my causes can be there? So this is why most guidelines advise investigations in RPL with the risk factor counseling. So that is in the next case discussion, we are going to do how to do the risk factor estimation. That is very important, because when to do what sort of investigation is the important thing. So this case is for Dr. Savita Rani Singhal. Just enumerate the etiology, and that will be a relationship of age and number of fetuses. Now patient was a Sonal, 26 years, married for 3 years again. She had 15th August pain abdomen, and 2nd September, she had collapsed follicle, Mittelschmerz was seen because she had come to the clinic that she was having pain lower abdomen. And the ultrasound showed that she had the mitral stone. So that means we are in a way confirming the date of pregnancy, conception also. So she came positive pregnancy after 5 weeks on 22nd September, and ultrasound at that time showed gestation sac of 14 mm and yolk sac of 4 mm. On 4th October, sorry. The UPT was positive on the 22nd. So when the ultrasound was done, there was no fetal hole. Gestation sac was around 6 weeks, 5 days, and no cardiac flicker, but yolk sac was seen. That was normal, and patient aborted on 15th October. What investigation? In this first case, should we do some investigation? No. Secondly, she came again. I had done this investigation. Dr. Savita Rani Singhal will talk on this. And she continued. She came again in May 22, and again on the 15th June, gestation sac and yolk sac was seen, but no cardiac flicker, and she again aborted. And should I give progesterone? Perhaps discussions later on, but we do sometimes, which is not supposed to be done. Should karyotyping of parents be done now? Urine, she complained of lower pain abdomen, so urine culture sensitivity was done. She comes back in the fever of 99 degrees in the second part of the cycle, and residual reaction is seen. Should APLA be done? I'll answer later on. So these factors for RPL, where do we start investigating from? Doctor. Now the question is, what are the causes of RPL first? Second cause is, because you don't know, what are the, this is the etiology of RPL, and second is risk factors for RPL, and what is the counseling which has to be there. So answer first question.
So coming to the causes, we've already discussed in detail. The causes can be, number one, 50% of causes is something which we don't know. It is unknown etiology. Number two, then the genetic causes, that is Mullerian disorder, genetic translocation, multifactorial disorders, chromosomal inversion. Dr. Isha has very nicely covered all of these. Then coming to the infectious causes, we know that TOT, CMV, all of these infections need to be covered. Then endocrinal problems like untreated thyroid problems, untreated diabetes mellitus, luteal phase deficiency, or any of the follicular phase defect can be one of these reasons. Then coming to the environmental factor like smoking, alcohol, then the other smoking, alcohol, and the weight issues, being very overweight or underweight. Then immunological causes like autoimmune diseases, where we covered APLA, and autoimmune diseases. Then the psychological factors, where can also be the etiology here. And other than that, can be acquired like the Asherman syndrome. Now,
that we will be covering later on in detail, all those factors. Now just tell me these factors for RPL and how we have to do counsel. What are the main factors for RPL?
So if we talk about main factors of RPL, coming to both the age, couple age, means male age and the female age, both are equally important. If we talk about female age, it has to be more than the risk of pregnancy losses above 35 is more. Coming to the male age, it is also because it also affects the DNA fragmentation. Then coming to the other risk factors like smoking, alcohol, PCOS, diabetes, hypertension, all of these are other risk factors to recurrent pregnancy losses.
Previous reproductive history, is it an independent predictor of future pregnancy loss?
Yes, previous reproductive history is very, very important because, and we need to know exact details, and we need to know exact detail of every pregnancy. Whenever we talk about, whenever we are taking history, we need to know everything in detail.
Because at 5 to 7 weeks, mostly they are genetic causes, 8 to 10 weeks, immunological causes, anatomical causes, and environmental and infections can also be there.
Yeah.
Now, what are the chances of a live birth who had one live-born infant with no prior fetal loss? Recurrence risk is 12% for the next pregnancy, but with at least one prior fetal loss, recurrence risk increases. So that goes on to 24% for the next pregnancy. And with 2 prior fetal losses, recurrence risk is 26% for the next pregnancy. So that is how we'll have to do the counseling. And with 3 prior fetal losses, recurrence risk is 32% for the next pregnancy. Women who have not had at least 1 live-born infant with 2 or more fetal losses, recurrence risk for the next pregnancy is 40 to 45%. That's why it's very, very important to know the number of pregnancies, at what gestational age they had, and how many losses were there. Now, this is very important. These are the charts which you can keep on your table itself. So this is the Kaplan-Meier chart, by where they show that by the age, if the patients come to you at a lower age, the chances of having a recurrent miscarriages are less, and live births after conception, or percentage of live births is much more. If the patient come to you at later age of life, like 40 years, then percentage of having a live birth are very less. So this is how you can do counseling. Same way, the number of miscarriages, if there were more than 3 miscarriages, then live birth rates it decrease, and if there were less miscarriages, then live birth rate is increased. So 3, 4, 6 miscarriages, your chances of getting. This is how we have to counseling of the patient, because counseling of the patient is the main issue which we should be doing it properly. So this is the same slides which I have shown, the percentages. The same chart is being again compounded with the age of the patient and the number of the miscarriages. And if you see, if the age of the patient is there, number of miscarriages is less, the chances of a successful pregnancy are more. But as the age increases and the number of miscarriages decrease, the chances of successful pregnancy, they decrease. So this is very, very important to do the counseling of the patient in this way, so that they will know what is their chances of having a live pregnancy in the next time. So that is how we can explain them that in case of unexplained, they can have a normal pregnancy also. So Pooja, Dhir, Bhaina, are the lifestyle factors important in these patients?
Yes, ma'am, of course, lifestyle actually has an important role to play, even in recurrent pregnancy loss patients, as various studies have actually, they have come to the conclusion that those patients who are actually obese, they have a higher risk of pregnancy loss. Overweight and obese, I would say 2 categories. Overweight, there is not much of difference between the normal pregnancy and in the overweight patient. But yes, in case a patient is having a BMI more than 30, definitely she is in a high risk category. Obese patients are in high risk category of pregnancy losses. Then second thing I would like to, in pregnancy losses, second thing, the lifestyle measure which needs to play a role is to quit smoking. Smoking is something which is having nicotine, and nicotine is actually a vasoconstrictor which can actually lead to placental insufficiency. And patients who smoke or females who smoke are actually in a category where they can have pregnancy losses. So yes, a patient who is smoking needs to quit smoking in case she is suffering from pregnancy losses. And alcohol is another thing. Alcohol studies are not very much clear because there are many of the confounding factors involved. But yes, alcohol itself is a risk factor in case a patient is alcoholic. In case a patient is having drinks per day, she can land into pregnancy loss. Then caffeine intake. Caffeine intake, very common. हम सब लोग coffee भी पीते हैं, सब कुछ लेते हैं. But higher caffeine intake, more than 150 milligrams per day of caffeine intake has been found to be associated with pregnancy loss. And
environmental?
Yes, environmental factors. Cigarette smoking, I said, I would like to stress on one thing, that it's not only active smoking, but it's also the passive smoking, which is actually responsible for pregnancy losses in case a patient is exposed to that. Then there are certain agents like anesthetists, they are involved in gases and they inhale gases. The studies are still not very much clear how much it is having the effect. Then dental people, they are exposed to certain chemicals. We are still not very much clear about those things which are actually affecting the pregnancy losses or not.
So from first visit itself, we will be counseling the patients about lifestyle modification. Most the couple, they should be there counseling, that it's not for one person, it's for both of them. These lifestyle modification has to be there. So, and secondly, we should tell each and every person about the environmental effects, because that is where I feel that this environmental change has to start from me. I can do it, I'll do it, I will don't throw the garbage, plastic, everything. So that has to start from me itself. So that is now we have come. Now the one question which I'll be asking, because the patients are coming to us, even one pregnancy loss is the we do routine antenatal profile at that time. And at least in my cases, I do everybody blood group, blood sugar, HPS, AG, HIV, VDRL, routine culture, and CBC, these and TSH. That is routine in all the patients. And I think with all the panelists will agree that this is the routine we are doing.
Yes, ma'am. These all are the routine things we are doing, because these are actually not very much costly, and they are the routine antenatal investigations.
Yeah, also. Routine investigations we are doing, and at the same time we are doing the ultrasound also. Most of the times we are diagnosing. So even 2D ultrasound can tell us about the septum or the shape of the uterus and everything. We'll be covering that later on, but that is what I'm saying, that even if the patient is coming to us with the routine checkup, we can do these things in the routine also. Now, this is the case which I think, yeah, Manisha Mehta, yes, you have to take this case up now.
Yes. Hello?
Yes.
You all, yes. Yes.
Your voice, from where have you joined? Mobile?
My voice is not clear?
Now it's clear.
Okay. Okay. Can you please show me on the screen?
It is there on the screen.
Okay. Okay. So you can see me. Before I actually take up my case, I just wanted to add a point about the environmental factors. We always talk about the external environment, but one point, the internal environment, that is stress, which is very, very important. And here comes our role, how we can, take care of that stress. It really helps. We have seen so many times. So the next question, Doctor, it's for you, Dr. Lakshmi. I will discuss two cases, almost similar cases. One of my patients is Seema, who's married for 5 years. And we see cardiac activity at 8 weeks, 9 weeks, and 7 weeks. And then once you see her after 2 weeks, there is no cardiac activity. And there's another case. She's a 28-year-old lady who's married for 6 years. There is sudden at 32 weeks, 22 weeks, and 18 weeks. Now she's pregnant at 8 weeks.
Right.
Dr. Lakshmi, my one question is, what is the diagnosis comes out to your mind once you hear these questions or these type of patients that come to you? What is the primary diagnosis which comes to your mind? And then I'll put 2 more questions to you.
Yes, ma'am. So, yes, ma'am. Yes. Looking at the history of the patient, if it fits into the criteria of antiphospholipid antibody syndrome, which is an acquired thrombophilia syndrome. And if we see the criteria, which we follow, that is the Miyake's 2006 criteria, which is in consistence with the Sapporo classification, which is given in 1999. So we have 2 criteria. One is the clinical and the other one is the laboratory criteria. And if we meet one clinical and one laboratory criteria, then we label the patient to begin to fit into the antiphospholipid antibody syndrome. So in this particular case, we can see the clinical criteria is met. The clinical criteria which we follow are among the 3 criteria, that is the pregnancy morbidity. First will be.
It's okay, Dr. Lakshmi. Now I want to come to 2 questions. This we have already discussed with Dr. Sujata in detail.
Right.
And we all know for Apela, we give low molecular weight heparin and aspirin. Can you please tell what doses, when time you start, and when do you finish?
Right. So, so we all know that aspirin and low molecular weight heparin
has really revolutionized the treatment protocol for the antiphospholipid antibody syndrome, and it has very good results. So as soon as we find the cardiac activity, we start with the low molecular weight heparin, which we give in the dose of 0.6 ml per day subcutaneously daily till 34 weeks of gestation. And aspirin we preferably give as soon as the patient conceives. We start with aspirin, that is in the dose of 75 milligram per day, and the aspirin also we continue till the 34 weeks of gestation.
Okay. Dr. Lakshmi, and to all the panelists and whoever are there with me, I want to put two things here. Even I was starting the aspirin as soon as the patient got pregnant, but something which, and I used to stop at 32 weeks because there was a risk of premature ductus venosus closure. But recently, you know, when I was going through all this, what I realized was that the aspirin must be started at 12 weeks.
Reset your internet.
Oh no, it's
not audible.
No, she's audible to us.
Okay. And the second thing I have realized is that we can continue it till term. There is no actual risk of premature ductus venosus closure. And the second point, as far as the heparin, the low molecular weight heparin is concerned, that we can start as soon as the cardiac activity comes and continue till the day you decide to deliver her. Some people do skip the last dose just 24 hours before, but I have, you know, operated on patients where we did not get that time of that 24 hours, and thankfully nothing happened, and we should continue it till 1 week of cesarean or howsoever you've delivered her. Now, the third question, Dr. Lakshmi, which I want to ask you, in all this kind of very typical cases, will you actually wait for APLA or the thrombophilia profile to come as positive, or is it fine that you will start her on this treatment with this typical history? So do you always wait for the positive result? Then,
so personally, if I say that, of course, if I have to follow the guidelines, then of course I have to get the test done. But personally, with such history, I would not wait for the results, and based on the history, I will start with the treatment for the patient.
Yes, absolutely. Dr. Lakshmi, what I want to communicate to all my fellow members is that we are always talking about the guidelines or people from America to tell us, but I just have one question. Suppose if you have a patient who's lost a baby at 32 weeks or 24 weeks, sudden IUD, no cause, the baby is absolutely normal. I think neither me nor my patient would like to wait for another chance. And second, the results of the tests are not that important.
Right.
So, over to you, Dr. Manin.
Ma'am, one thing I would like to contribute.
Yes.
Yes, Pooja.
Hanji, ma'am. The recent guidelines are, I think you can start heparin even at UPT positive. We should not wait for the cardiac activity to come. We can start it as soon as the UPT of a patient is coming out to be positive.
Can we done together both aspirin, ecosprin, and heparin together? LMS, low molecular weight heparin and ecosprin can be given together, because when given together, they increase the chances.
They have a better pregnancy outcome.
Given
So
alone.
aspirin in our patients, when we are already dealing with a patient who's APLA positive and she's planning to conceive, we usually start the aspirin prior to conception also. And when a patient conceives, we start with the low molecular weight heparin.
And in case of IVF pregnancy,
that is what we do personally. We do, but the guidelines, like there are a lot of studies still, and the guidelines do not say that.
And in case of IVF
guidelines
pregnancy,
also say that we can start earlier. Guidelines also say
Once
that
your
we can start
pregnancy test
earlier.
is positive, we can start with the low molecular weight heparin.
But that
for what indication we are using it, it is important. If it is a patient who is conceiving spontaneously and is having recurrent abortions, the abortions are likely to happen in antiphospholipid antibody syndrome at the time when the cardiac activity repair, because the thrombosis will cause the IUD at that time. But the thrombosis is going to affect the placenta slowly, and it may end up in IUD later on at any time. So for what indication we are using, whenever we are sitting in a webinar, the message has to be very crystal clear that if it is a patient who is having recurrent abortions, we have to have the cardiac activity coming in after. We should take it at 1 month, 18 days or so, 1 month, 20 days. We should start the treatment after that. Giving ecosprin or heparin in the luteal phases for some people who are not conceiving otherwise, and you're treating infertility for certain causes.
Ma'am, we are talking about
RPL.
patients who are proven
If
APLA
the patient
positive,
is
not
spontaneously
APLA positive
conceiving,
patients.
no. If the patient is spontaneously conceiving and you are having a patient who, the case which you have put forward is where the cardiac activity has appeared and then disappeared. So patient has conceived, embryo has formed, cardiac activity, the fetus has formed, the cardiac activity has appeared and then it is disappearing because of a disease in the mother, that is the antiphospholipid antibody.
But
so we have
can
to
be
keep
started
what we
by
are
treating
discussing.
infertility.
Ma'am, I'm
So
talking
why
about
we are
APLA
going to the
positive patient
luteal
for
phase?
recurrent
Why
abortion.
we are going to the luteal phase and starting heparin there? It is not indicated starting there.
Ma'am, we are here talking about APLA positive patient, proven APLA positive patient, where you have
Yes.
the biochemical reports coming out to be APLA positive. There you can start once you get the pregnancy test positive.
Yes. Yes, for that
How
matter.
the etiology is going to affect at that time, no? How the etiology is will cause a abortion at that time. That you should start it so early. You may end up half of the pregnancy
So the
getting lost
process
by
starts
bleeding.
early. That
The
is,
process starts,
that is,
yes,
the
the process
process is
starts
already
early.
there.
What
Even
case we are
aspirin will
taking
act
is
in
after the
patients.
cardiac flicker is coming.
No, but aspirin can always be started before, even by treating the infertility patients, or even if the patient
is not
start
conceiving
aspirin then
spontaneously.
also. And
Yes.
continue, yeah. Maybe the patient is apprehensive about taking injections, but aspirin we can always start earlier and it will have beneficial effect even if it is APLA positive.
Right.
Okay.
How it is going
So but it has been mentioned in guidelines, ASHRAE guidelines especially, then when the patient is APLA positive, and the patient had come to me in the mid-cycle itself, when we have confirmed that the ovulation has taken place and might the patient will conceive in this cycle, I think because ecosprin is safe, we can start it. Heparin, we can wait till the cardiac activity comes up. Can we agree on that?
Yes, ma'am. ASHRAE guideline says that.
Aspirin can always be started.
So now there is just one thing which I want to mention. This study, I read it today only. And this is the latest study in 2022. It means because of the COVID-19 scenes, the positivity of LA in the setting of a viral infection is frequent and not specific to APS. During the COVID-19 pandemic, many patients developed arterial and VTE that could suggest testing for APLS. The association between LAC and the risk of VTE or in-hospital mortality in hospitalized COVID-19 patients was not demonstrated. Moreover, APLS don't persist after COVID-19. Currently, testing for APLS in COVID-19 patients is not recommended. So patients are still coming to us positive. So avoid doing APLA studies during that time. When they come negative, then do it, these studies, because then they won't give you the right information. Now, another case, now we come to because we don't have much of a time, so let's hurry up. So patient Manju Rani, 28 years, married for 3 years. This is for Rubina. Patient Manju Rani, 28 years, married for 3 years, spontaneous pregnancy, but she had history of 3 abortions and ultrasound confirmed fetuses were there at 17 weeks, 23 weeks, and 15 weeks. Now, what are these abortions they are pointing towards? Rubina?
Yeah. So, ma'am, since there are 2 points.
Sometimes we have to look into the history and try to find out what we might be coming up to. Yes.
I think history is giving us a lot of crucial information here. One thing that it is telling that the patient has gone through painless abortion, which takes us more towards cervical incompetence or any of the uterine abnormality. Second, patient has second trimester abortion, which also takes us more towards the structural abnormality or the uterine abnormality causes abortion. Now, most likely this looks like anatomical factors, anatomical factor as a reason for abortion in this case. Now, it can be either cervical incompetence or it can be any of the Mullerian abnormality. It can be septate uterus, it can be bicornate uterus with normal cervix, or bicornate uterus with 2 cervix, or unicornate uterus, or any of the acquired reasons of second trimester abortions, like multiple synechias or polyps or fibroids. Synechias are less common because then it also will have poor implantation and patient also might not get pregnant spontaneously. So I think the diagnosis more goes towards second trimester abortion and also towards the anatomical cause of the anatomical reason of recurrent pregnancy loss.
How do you diagnose them? What are the investigations you are going to do?
So it's very, very critical. The history is very important here. After the history, the ultrasound is gold standard here. Either 2D or 3D ultrasound, both are very valuable techniques. Doing SSG, if you are in a place where 3D ultrasound is not available, then SSG can also be done, is also gold standard. But MRI is not recommended in such cases. Very valuable information can be fetched out of these basic ultrasounds like 3D and 2D ultrasounds.
Anything important in these Mullerian duct anomalies which we should be looking into? Other systems?
Yes, so we should also investigate the same patient for kidney abnormalities and urinary tract abnormalities here.
At the same time, ultrasound probe can be taken upwards and we can do the same thing.
Yes.
We should not forget to do it.
Yes,
that is very important carry home message.
But actually it's very, I mean, because she's gone through 3 similar type of abortions, and we should not miss uterine abnormality, at least because we have very good ultrasound available now. We should not miss this kind of diagnosis at all.
Hysteroscopy, role of hysteroscopy in the diagnosis and management?
So if you're doing hysteroscopy for reason, I think for diagnosis, probably we have ultrasound, 3D ultrasound, which is very, if it's done if it's done properly, we have like adequate information to fetch out of it. But if we are in dilemma and we are not able to diagnose it somehow, then probably hysteroscopy should be done, and the operative should also be taken care immediately in the same sitting.
If you are reading Journal of Midlife Health, read in this issue, because now I am the editor-in-chief. We are advocating now doing the OPD procedures of hysteroscopy for all the gynecologists, because that is what is going to reduce the cost and give the less time also, earlier and cost effective and friendly for the patients also. If we start doing our OPD hysteroscopies and diagnosing, and even they say polyps and small synechia, they can be looked after in the OPD procedures itself. So please, let's start looking in those directions also. We can now move forward in that direction. Now this question is case for you.
Dr. Deepa? Dr. Deepa?
Dr. Dipika, ma'am. Dr. Dipika.
Deepa Agarwal.
Deepika Agarwal.
Maninder, how many more cases, because we are getting late for the second passage?
Yes, must we are.
Can we take this last?
Only,
can we take this last message, Dr.
Only this one. Only this.
Okay,
is
done.
One case
Okay, okay. And I'll just talk about Dr. Dipika. I'm sorry, the name is written not properly. So my question is, now since we are talking about cervical incompetence, we all know that we have to apply a McDonald stitch, and at times we require abdominal suture. My question is, we have all seen, all of us have seen that this stitch gives way so many times, because it's a very easy stitch and we all can apply it very nicely, but still at times this stitch gives way. So can you suggest some things so that the stitch should not give way? What could be the possible cause, and what are the suggestions for all of us sitting here?
Yes, very important.
So over to you, Dr. Dipika.
Good evening, everyone. And first of all, cervical cerclage. Cervical insufficiency is the inability of the cervix to retain the pregnancy in the second trimester without the signs of labor. And this is the painless cervical dilatation. And for this, we suggest the cerclage operation to the patient. And in this, we have options of, yes, ma'am, please.
My question is, Dr. Dipika, my question is very straight. How should we, I mean, what are the causes of this stitch giving way, and what suggestions do we have for all the members sitting here so that we minimize this stitch give way?
You are talking about McDonald's stitch.
Yes, yes. I'm
But
talking
there
about
are
the
three
McDonald's
levels. You are
stitch.
doing at lower level. You are doing this rescue circulars, and then you are doing the higher up. So when you are doing the McDonald's stitch, at that time, how we can prevent it?
No,
Maybe,
my question is that so many times we see out of 100 stitches you've placed, probably 5 or 7 will have some problem, and you will have to either remove the stitch or it gives way. It opens by itself. So my question to Dr. Dipika or whosoever, all my panelists is, do you have any suggestions that to reduce this chance of this stitch giving way?
I would screen my patients prior to the circulars. I would like to get the cultures done for my patient.
Very good, Dr. Rakhee. Oh, Dr. Pooja, yeah?
Ma'am, I would like to get cultures done for my patient, urine culture,
Yes.
as well as I would send a cervical swab for culture sensitivity prior to applying stitch, so that in case she is having any kind of infection, that can be taken care prior.
Yes.
Prior to
That
application
is
of the stitch.
that is one very good message I wanted to give to everybody, because initially I would see more of stitches giving way, but now I always do a circular stitch when there is no infection. Second, once we have applied the stitch, I always advise that a cervical or a vaginal swab should be done repeatedly. Repeatedly means I'm not saying every day, but once the patient comes to you, maybe once in 2 months. And I always give antibiotic prophylaxis once I put a stitch. So this message I wanted to communicate. And over to you, Dr. Maninta ma'am, to finish.
The length of cervix also matters. To correct time of placement.
Dr. Jitendra, it is fine. But the most important reason for the stitch to give way is infection. I have seen
before any tiny procedure.
I have seen patients with 1 2 finger or 2 finger dilatation, but they will keep on continuing with their pregnancies for months and months without a stitch, just because we take care of infection. So this is one thing which I wanted to.
Infection, yes, we can.
One thing more, Dr. Manisha, we can put the
Yes.
patient on probiotics also.
Yeah, that is
Continuous
what I was
probiotics.
telling
Yes, ma'am. Yes,
Yes.
Dr. Chugh, absolutely.
Yes.
Absolutely.
Second
Yes.
trimester, we should put them on probiotics, which
Yes,
will be
yes.
very
the role
helpful.
of probiotics and the bacteriomes is coming up now. So endocrine, Dr. Singla, she has joined or not? Dr. Savita, hello, are you there? No. So endocrine factors.
Ma'am, I will request to I will request to
wind up now. We are winding up
because second panel will get less time.
Yes.
Yes.
We are also anyway. I am winding up. The endocrine factors, all of you know, is the diabetes well controlled, PCOS well controlled, is going to be not a cause for the RPL, and we have to treat itself. Hyperinsulinemia, we can give the metformin, but for the prevention of RPL or the treatment of RPL, it cannot be given. But for other indications, it has to be given. Hypo and hyperthyroidism, I think all of you know, when the hypothyroidism is there with antibodies, we can always have to start with the treatment. And in the overt hypothyroidism, we have to start. But if it's a subclinical hypothyroidism and the patient has the antibodies present, then we have to start the treatment. And when the patient becomes pregnant, she was already on treatment, first trimester itself, raise the dose of the thyroxine by 30%. That is very important. Role of progesterone is again coming the promised trial. It's not there, but we have been using it. We will be using that question along with when we are giving these circular stitches. Do we use progesterone? All of us for uterine quiescence, we are using it. So, but the promised trial said ki we no use. But of course, when the cervix is short and the history of recurrent pregnancy loss is there, I think we are justified in giving the progesterone, and future studies are still needed to clear this issue. Hyperprolactinemia, if there, we have to give the prolactin, immune system, and genetics will be taken up, cytokines by the other panel, I think. So we won't think corticosteroids, they don't have any role to play, and they will increase the complications. So please, restricted and no, not advisable until unless indicated for some other indication. And I think because she's not there, infective causes, bacterial vaginosis we have to treat. And as Manisha said, if there is a local infection, we have to treat. Endometritis, we has come up that immunohistochemistry and microbiota, they have a role to play. And that points we have discussed, and even Sujata, she has taken it. Genetic factors we are not taking into, and one, women with recurrent, and second, should be looked after by a health professional with the necessary skills and expertise, and where available, this might be within a recurrent miscarriage clinic. So that is the idea, where we have a genetist, we have a good ultrasonologist, we have a good clinician, and all these combined, and a lab facilities which are there, which can do all these your lab investigation whenever required. Male factor we are not discussing, because if it is there, it is there now, so we should be doing DNA fragmentation in the, and male semen should be tested thoroughly. When needed, perhaps we have to take the services of ART also in these patients. I don't have any solution, but I can certainly admire the problem. That should be their problems, admiration, because these patients, they need our counseling, our psychological support. That is very important, and we have to address them properly. And the insufficient evidence, please, I have to just mention them. Luteinizing hormone levels by HCG, or there is insufficient to ovulate metformin for prevention, I said. Immunotherapy, paternal cell immunization, third-party donor leukocyte, trophoblastic membranes, intravenous immunoglobulins, they don't have any role to play. But we need these miscarriage clinic, and we have to understand their stress of the patients, which is very, very high in these cases. And unexplained recurrent miscarriages in 75% of the patients. If we give them tender loving care, that will improve. The power of love to change bodies is legendary, built into folklore, common sense, and everyday experience. Love moves the flesh, it pushes matter forward around. Throughout history, tender loving care has uniformly been recognized as a valuable element in healing. Thank you very much to all the panelists, to ISAR chapter, and for the delegates who are there to attend. Please give them a tender loving care, and whenever needed, do the proper investigation, proper care. Thank you very much.
Thank you, Dr. Maninder. Since we are very short of time, so I thanks Dr. Manisha and Dr. Maninder for a very nice panel. And please move on to, I request my chairpersons to invite the moderators of second panel. I request my chairpersons, Dr. Jitendra Chadda and Dr. Dipika, to please invite the moderator of second panel. Okay, then I invite Dr. Jyoti Malik. Are you there, Dr. Jyoti Malik?
Yeah, Dr. Rakhee, I'm here. Thank you.
Hello. Welcome, Dr. Jyoti. She's, I think Dr. Neeru Thakral, are you there? Dr. Neeru Thakral, she's a director at Thakral Hospital, and Dr. Jyoti Malik is the director of the JJ Hospital, Bahadurgarh. I think everybody must be knowing Dr. Jyoti Malik. She's a dynamic personality, and she owes so many publications and so many posts. And due to shortest time, I might not be able to go through whole series.
We'll skip this. Yeah,
we'll skip this.
Yeah.
And I welcome Dr. Neeru, who is a past president of Indian and she's also non Dr. Amit, please play the slide of panelists. Mr. Amit Saxena, please play the slide of panelists.
Thank you, Dr. Rakhee. Yeah, can I share my screen now?
Please introduce your panelist first.
Yeah.
Dr. Jyoti, you can introduce your panelist.
Yeah, Dr. Neeru is doing, ma'am.
Okay.
Thank you very much, Dr. Renu and Dr. Rakhee, for being us all here. And thanks a lot. And congratulations, Dr. Nandita Palshetkar ma'am and Dr. Sujata for the excellent series. So I have my co-moderator, very sweet and loving Dr. Jyoti Malik. And we have vibrant panelists with us, Dr. Seema Mittal. She is past President Rewari Obs and Gynec, and she's a very dynamic personality. Next, we'll have Dr. Sangeeta Jain. She is also from Ambala, IVF specialist. Dr. Sakshi Bansal. She's from Sonipat. She is also IVF specialist. She's from Sonipat. Dr. Divya Agrawal, she's a geneticist. She's from Apollo Hospital, Delhi. I like she can counsel, how she counsels the patient, very patient-friendly approach. Dr. Ratika Jindal, she is also IVF specialist from Rohtak. So with this, I'll start my panel on genetics in the RPL. So since evening, we are listening all about the RPL. So now we come to the genetics. We all know that 50% of the cases can be attributed to genetics such as aneuploidy. Technology is evolving since the start to achieve this goal. So one of the most common problems encountered in genetic abbreviations, we can prevent it from the transmissions. So we have various genetic factors. We all know more than 40% if the age is more than 40, but it's 9% if the age is less than 35. And all the factors very nicely described by Dr. Sujata, Dr. Maninder. So genetic factor also contribute 2 to 5% of the cases. So what are the types of chromosomal abnormality, Dr. Seema Mittal, we can find?
See, there are, we can have either the chromosomal anomalies or the gene defects. So we have the aneuploidy, which could be trisomy, monosomy, or tetrasomy, or we could have the single gene defects. And these are the various types of anomalies that we come across.
Yeah, so very well described. In the recurrent pregnancy, most common is the aneuploidy, then translocation, deletion, and inversions. These all can cause recurrent pregnancy loss, miscarriages, embryo death, and even congenital anomalies. Genetic factors, they all contribute even 50 to 60%, especially most common is the balanced translocation. Robertson causes 40%, reciprocal causes 60%. Trisomy and polyploidy and monosomy are also the common causes in these patients. So clinical workup, what clinical workup will do, Dr. Manju? Patients come with a history of recurrent pregnancy loss. So which test you would like to do for the genetic counseling?
For recurrent pregnancy losses will depends on the when the couple comes at once. If there are 2 or 3 pregnancy losses and she is not pregnant, she is coming for the next consultation, then we go for the couple karyotyping first to look for the any aneuploidy in the number, or we can see the balanced translocation in the karyotype only. If couple comes in a stage of missed abortion or miscarriage, then we can go for product of conception for the genetic analysis. Like we can do for POC microarray to look for any genetic abnormality in the POCs.
Yeah, so we are not doing karyotyping because of the risk of culture failure. So nowadays we all are doing the microarray, and we know how to give the sample, how to store the sample, put in the fridge, put few drops of antibiotic, any antibiotic, gentamicin, tobramycin, or anything we can put. But yes, cold storage is very, very important.
So
And-
here one point we want to highlight over here is I listened the previous discussion also how to send the sample of POCs for microarray test. We send the sample microarray test is very correctly said that we send in the normal saline with some antibiotic, but we must not forget to send the maternal blood sample to rule out
That is
contamination.
very important. That is very important. We always send 3 ml maternal samples along with that. And karyotyping is outdated because of the risk of culture failure.
Yes.
Yes, what are the drawback of the microarray? Dr. Sangeeta, what are the drawback? What is the limitation of microarray, I can say?
Microarray can tell all the details of like smaller details of chromosomal causes of recurrent abortions, but it cannot tell about the balanced translocations which have happened. This cannot be done in this. Second thing is it is very costly and cannot detect. Everyone cannot afford the microarray testing. Third thing is we cannot detect the smaller like genetic defects, single gene defects, and the very, very small deletions in this. And for that, we have to go for single gene defect tests like NGS or further full exome sequencing. So these are the few of the drawbacks of this microarray. And in the and the advantage is that the results are faster and we can detect most of the anomalies in this.
So perfectly described by Dr. Sangeeta that we can check the unbalanced translocation, but balanced translocation, copy number variations, all these things we cannot detect. I think we are on the right track, Dr. Divya.
Ji ma'am, bilkul, absolutely, yes.
So now we come with the case scenarios. So we have different cases. So first case is patient A, 30 years, married for 8 years, case of recurrent pregnancy loss. She has history of 5 abortions. All were the early abortion. Cardiac activity present in 2 and not present in the 3 cases. All investigations were normal. APLA was also normal. Ultrasound 4D was also normal, CD438 also normal, everything, DNA fragmentation also, everything was normal. But on the wife karyotyping, we can see the report is reciprocal translocation between the long arm of chromosome 12 and 13. So patient was advised PGT-SR. Genetic counseling is done for the patient before going for the PGT-SR. We tell the patient for the genetic counseling. Patient was for IVF only. So we did the IVF, taken the embryo to blastocyst. 6 blastocysts were formed. On PGT, only 2 embryo were only euploid. Rest 4 were PGT-SR variation. So in May, single embryo transfer was done. Patient beta SCG came positive. Now patient is 4 months pregnant and level 1 scan is also normal. Double marker is also normal. So PGT, what is the new terminology for the PGT? Dr. Seema Mittal.
See, earlier it was pre-genetic terminology was pre-genetic screening or the diagnosis, but now we say it is pre-genetic testing. And this is to determine if there are any genetic defects, but we have to be really careful when we are diagnosing patient, because what we are doing in PGT is that we are taking the trophoblast ectodermal cells for diagnosis, and inner cell mass is not touched. And normally what happens that inner cell mass is just pushing the cells to periphery. So the test is not very diagnostic, and there are very specific. So new terminology has now been pre-genetic testing, which is done for patients who are either high risk, they are elderly patients, or recurrent pregnancy loss. And in IVF, we do it for patients who have got recurrent failures. To me, it is.
What is the new terminology? Like earlier, we used to say PGT-S and PGT-B, but now PGT and PGT-S is outdated. Now we call PGT-A, M or SR. Yeah, SR is for the structural defect like deletion, duplication, translocation. M is for the monogenic or single defect. So this is a case of PGT-SR because we have found this structural anomaly about the Robertson translocation. So what lab is required for PGT? Dr. Manju Daggar?
Yes. Lab requirement for reliable is first of all, we should register with the PCP NDT. We should have a registration certification.
Very important. Yeah, very,
And
very
second
important.
is we need to do a counseling for the PGT. What are the limitations? And we should have a good genetic counselor just to tell them, okay, what is the technique, what is the limitations, what are the benefits. Third is we need to fill the consent forms for the before testing. We should I tell the forms also? No.
Yeah.
Okay.
And lab required QA/QC should be completely maintained.
QA/QC should be
Quality control
completely,
is very, very
embryology should be well trained, ICSI should be there, ICSI machine and biopsy needle and all should be there. Before biopsy, we should decontaminate our lab to avoid contamination. And decontamination not only with the ethyl alcohol, we should use bleaching or UV radiation 12 to 24 hours before our embryo biopsy to avoid contamination in that. We should take biopsy, we'll then label the embryo, and then we send the biopsy for genetic testing in the lab.
Yeah. So
And
thorough
we take the
QA/QC is very
biopsy, we freeze the embryo, we wait for the result, and then we should see which embryo has which result, and we can transfer only the euplied one.
Yeah. So which consent form we are filling for the audience?
The consent form we are filling is Form D, Form F, Form E, Form G, and E if you have in-house genetic lab.
Yeah, Form D, Form G, Form F. These three are very, very essential for the PGT.
But if you are doing genetic test in your lab, you have in-house genetic lab, then E also.
D, G, and F. These three are very, very essential. And what new ART law says that PGT testing shall be used to screen human embryo for known pre-existing heritable or genetic disease. Like in this patient, we have found the heritable disease of translocation, or when the medically indicated. That means we can do for PGT-A also if the age is more than 35, because it's the medically indicated. But not just patient says, no, I want to do PGT, do my PGT, we can't do like this. This is a new ART guideline. So now we come to case scenario 2. She's married for, I'll just quickly go because we are already running late. So patient B, 40 years, married for 10 years, all conception on treatment. She has 3 missed abortion at the age of 7 to 8 gestation. All testing was done. Karyotyping was advised for parents to trace the translocation. On para 1, 4-year female, level 2 anomaly scan normal. Coronal plexus cyst in the brain, echogenic cardiac focus, amniocentesis was done and diagnosed balanced translocation in one of the fetus. So karyotypic advised to trace the location. Translocation on karyotyping, father was found to have the translocation. Here, not the mother, father was found to have translocation. And we advised the patient donor also, but patient was not ready for the donor. Patient want their own genetics gametes only, but the wife, because AMH was 40, she also wants her own gamete. We did the pooling 5 times this patient, 9 blastocysts, but all were abnormal. But still patient was not ready for the donor sperm. Ultimately donor eggs was taken. Now 7 blastocysts were there, 1 euplied embryo and transfer, and patient is having healthy baby. So this is the scenario, this is the drawback. We need the pooling so many cases, especially if the age is more than 40. So pre-implantation genetic testing is only for the patients at risk for chromosomal gain and loss related to parental structural chromosome like translocation, inversion, deletion, and insertion. In general, PGT-SR is only recommended if the technique applied is able to detect all expected unbalanced form of the rearrangement. So this is another case now, third case. She's patient XY, secondary infertility. She was also registered from IVF. Both and husband and wife were looking from abroad, Nigeria, married for 5 years. She has first abortion at the age of 6 weeks. POC's microarray shows monosomy. AMH is also lower side 1.2. Semen analysis slight oligoasthenospermia. DNA fragmentation 28. Patient doesn't want to take any risk. Earlier abortion also was showing monosomy. Age is more than 38. So we advise the patient PGT-A. 7 oocytes was retrieved, out of which 4 blastocysts were formed, 2 were euploid, 1 mosaic, and 1 aneuploid. 1 euploid embryo transfer and beta SCG was positive. So our aim of IVF is to give a healthy disease-free child in minimum possible attempts. So now I come to Dr. Ratika. What is the aneuploidy? PGT-A here we are discussing. What are the type of aneuploidy? Dr. Ratika?
Ma'am, aneuploidy is a condition in which we have abnormal number of chromosomes. It is due to the non-disjunction of the chromatids during the process of the cell division. We have 2 processes of cell division. One is meiosis and other is mitosis. So when the chromatids are not able to dissociate properly, one of the cell gets an extra chromosome, whereas the other cell gets 1 less chromosome. So there are 4 types of aneuploidies. Nalisomy, where there is complete absence of 1 set of chromosome. Then there is monosomy, when there is deficiency of 1 copy of the chromosome. Then the most common aneuploidies are the trisomies, where we have 1 extra chromosome, like in chromosome Down syndrome, we have 1 extra 21st chromosome. Then tetrasomy, where there is complete 1 set of the chromosomes is present.
Yeah, very beautifully explained. Dr. Divya, you would like to add anything, or you would like to tell the audience which are more common in these, Dr. Divya?
So that very rightly said that, aneuploidies is a difference in the number of the normal 23 pairs of chromosomes. So, any chromosome which gets left behind, or any chromosome when there is an extra number of that particular chromosome, that we call as aneuploidy. So it occurs due to the defect in the non-disjunction, and a lot of recurrent miscarriages are due to monosomies actually, and a lot of them occur due to the monosomy of the X chromosome, and a lot of them occur due to the trisomy of the chromosome number 16. So these are the ones which are very common. So trisomy 16 is one of the commonest cause of miscarriage, not a recurrent miscarriage, a miscarriage. Aneuploidies usually are sporadic events. They will occur by chance, coincidentally in one of the fetus, and they will usually, not recur again and again. So aneuploidy is an important cause of an early miscarriage, but they will not be causes for recurrent miscarriages.
Yeah, but it is very
Usually.
important because so we have to send POCs for karyotyping,
Correct.
for
Absolutely.
counseling the patients.
Yes.
Because patients are very, very demanding. So very important to counsel the cause, because 50% we can find the consult.
So it is important to, find the cause, pinpoint the cause, so that, next time we know that it was an aneuploidy and there is no increased risk because of that particular aneuploidy that we detected.
Suppose patient doesn't want to go for PGT or IVF. So what other counseling will do to this patient, Dr. Divya? How can she go then? She can have normal pregnancy also.
They can have a normal pregnancy. As you said that the AMH is a little low, but if they are able to conceive naturally, I don't see any risk of this particular couple having a recurrent miscarriage or a miscarriage, because they have, there is the sperm count, the semen analysis is a little on the, it's not up to the mark, and AMH is a little low. That's why, probably this couple came to you for an age as well. So of course, if they want to go ahead and plan a natural pregnancy, you'll have to counsel them about the age-related risk again of a chromosomal abnormality. And then, if they have to go ahead, we will advise maybe an NIPT and a double marker as usual.
Yeah. So what is the other indication of PGTA, Dr. Sangeeta?
First of all, the age is the most important factor. We have to find out the age of both male as well as female partners. Number 2, the environmental factors, they can also lead to the sporadic cases like Dr. Divya has said, it is the most common cause of abortion, not the recurrent abortion. So environmental factors like smoking or pollutants in the environment, or alcohol or obesity or excessive exercise, that can also lead to or even the stress can lead to the aneuploidies. And the other thing which I could see in the sample was oligoasthenozoospermia. It could be related to a male factor, like the male could have the other reasons also for this zoospermia. So the male should also be consulted and should be tested for the reasons of oligoasthenozoospermia. So
very rightly, briefly told, advanced maternal age, recurrent pregnancy loss, recurrent implantation failure, patient wants single embryo, or the male factors, oligoasthenospermia. So these are the indication for PGT-A. We can see the risk of aneuploidy increases sharply after the age of 35. At the age of 40 to 50, it's around 50% risk of aneuploidy. So this is also STAR trial. They have seen in 35 to 48, the risk is more than 50%. So which genetic testing you will perform nowadays, Dr. Divya? Out of FISH, PCR, CGHS, array CGHS, NGS, which testing we are doing nowadays?
So for the PGT-A, if you're asking me that, for all the pre-implantation genetic testing, we are using now next generation sequencing. All the other tests for chromosomes like karyotype or a chromosomal microarray, that is all the array-based tests, then FISH-based technologies, QF-PCR, these are all the other tests that we usually do for any other sample for a chromosomal abnormality or for an aneuploidy. But in the setting of the pre-implantation genetic testing, now all these PGT aneuploidy, structural rearrangements, as well as any other test, it's based on the next generation sequencing. So it uses NGS as the technology, even for
sensitivity is
aneuploidy.
99.9% and sensitivity is 100%.
Absolutely.
NGS platform.
Correct.
So what about the mosaicism, Dr. Divya? And
so now, yes, so there are clear-cut guidelines now with regards to mosaicism, and we say that, more than 30%, if we are finding the mosaicism, then only we consider it as significant. If it is less than 20 to 30%, then we consider it as euploid, and then there is no controversy about whether to implant or not. But it is between this 20 to 80%, which we actually consider as mosaic. So mosaicism actually means
less than 20% and up
20 to 80%. So more than 80%.
And what is mosaicism otherwise?
Yes.
For the
public. Mosaicism is basically the presence of an abnormality in a partial state. So when we are picking up the cells, then when there are more than 2 or more chromosome cell lines, basically different chromosomal complements which are present within the same embryo, then we call it as a mosaicism. So when we are taking a biopsy, if some of the cells, if more than 80% of the cells are showing a chromosomal abnormality, then we classify it as a totally aneuploid embryo. However, if less than 20% of the cells show an abnormal chromosomal complement, we consider it as normal, because it has been seen that, when the abnormality of the chromosomes is present in less than 20% of the cells, then it usually self-corrects in the embryo, in the fetus. As the fetus grows, the cells which are normal, which have the normal chromosomal complement, they will outgrow the cells which have the abnormality, and hence less than 20% we can implant. Now between 20 to 80%, the mosaic ones, it has now been said that, that if it has been seen that because of this reason that the embryos, they tend to overcorrect, they tend to correct the abnormality, nature tends to correct the chromosomal abnormality, it is now said that, the mosaic embryos can also be implanted. However, the family has to be told that, the chances of implantation will be obviously less than the euploid embryos, but still they are not as much as the aneuploid embryos, and it is just the implantation defect that we are looking at. If the mosaic embryos get implanted, then usually these fetuses, will not have any developmental abnormalities, because when they get implanted, it automatically probably means that the abnormality is in the process of getting corrected. However, Yes, it gets auto-corrected. So implantation chances are less, but there are no chances of any additional developmental problems in these fetuses. That is what has
Dr.
been said.
Seema, which prenatal test you will do? Now this patient has conceived. So which test you will advise this PGTA patient, Dr. Seema? You would advise any prenatal testing for this patient?
We will keep this patient in strict follow-up, and we will go for other tests like dual marker, and we will do NIPT also, and the neural tube defect also, the level 1 scan. And then later on also in follow-up, she has to be there.
Yeah, but if we transfer mosaic embryo, then we can offer them invasive testing also. Otherwise, non-invasive is enough for PGTA cases.
Right.
PGTM cases, we definitely go for the invasive test. Am I right, Dr.
Yes, yes, ma'am, absolutely.
What is the limitation, Dr. Manju Dagar of the PGTA? What are the limitation and counseling? Briefly, can we just enumerate, Dr. Manju?
Yes, we can counsel the patient about the PGTA, because PGTA, when we are doing usually in the advanced maternal age, when there is some problem is going on, like recurrent implantation failure and all. And in these cases, already there are very less chances of formation of good number of embryos and good quality of embryos. So we can counsel the patient if we can land up in no formation of embryo, like we are landed up and there is no formation of embryo, blastocyst is nil, and we are not reached to the point of biopsy. And if we reach to the point of biopsy, there may be 1 or 2, and there is a possibility that if we get 4 or 5 blastocysts, all can be abnormal. So you can land up in nil transfer in that cycle. And there are limitation of the technique also, because there is mosaicism, there is false positive and false negative cases. So we should not, then we give the choice to the patient. If we found all embryos are abnormal, then you want. If we find all embryos are mosaic, and suppose we have some percentage, some are euploid, some are mosaic, some are aneuploid. If we find only aneuploid and mosaic, what do you want? Do you go ahead for transfer? Because in embryo, self-correction hypothesis is very important. And in blastocyst, we are taking biopsy from the tropho. We are checking the placenta, we are not checking the inner cell mass. We are not checking the fetal constituents. So in that cases, if we are go ahead for the transfer also in these cases, I should recommend they go for confirmation test in pregnancy. So all these options, all these steps need to be counseled to the patient, so that patient can take the right decision for the technique.
Yes, we should explain that sometimes we are helpless. We are left with no embryo for transfer. So we should thoroughly counsel everything. And we know in the advanced age, 39 to 40 years, out of 11 COCs, we have only 1 euploid embryo. And after 42 years, even from 18 COC, we have one euploid blastocyst. Sometimes we doesn't have blastocyst. So these are the situation. Like this is the case, all the 10 embryo, one is monosomy 21, 22, trisomy, monosomy 16, chaotic. So we have left only 3 embryo. So all this situation we should thoroughly explain to all these patients. This all counseling we have explained very well by Dr. Manju. So PGTS cannot be recommended to all. Advantage and disadvantage are 2 sides of a coin. In selected patient, it's definitely helpful. We can transfer them single embryo, especially they doesn't want to take the risk of miscarriages also. They want single embryo transfer. So this is another interesting case. 34 years female came from a couple is consensuous marriage, consulted for genetic counseling for the IVF. Or one of the patient lastly came, they want donor, but they doesn't want to take any donor chances of anything, any baby should be healthy. They doesn't want to take any genetic abnormality. So which test you would like in these patients? Dr. Divya, can you please explain?
So in a consanguineous marriage specifically, there is a slightly increased risk of the single gene disorders called the autosomal recessive disorders. And, when such a couple presents to us beforehand, we usually tell them that the option of a carrier screening, which means that, both the husband and the wife, they are checked for being any carriers for any single gene mutations for the severe genetic disorders which could be recessive in inheritance, because in the recessive disorders, the risk of recurrence in the babies is high. It is about 25%, and in a consanguinity, of course, the risk of recessive disorders increases. So we do offer carrier screening, which includes, sort of, it's a single gene test which looks at a panel of 1,500 to 1,500 genes, which are severe genetic disorders, along with testing them for the common genetic conditions like SMA and Duchenne muscular dystrophy. So we do offer them these tests.
You would like to go, which test you would like to go for the donor, and which test you will like for the couple with the consanguineous marriage?
So consanguinity, of course, the couple carrier screening test, and for the donor also, actually a carrier screening is actually enough, and that is what is recommended. However, a clinical exome or a whole exome is a much wider test, and it can also be given, offered, but a carrier screening is what is recommended, because that sort of includes only the genes which are actually actionable by prenatal testing and pre-PGT testing recommended by ACMG, because they actually are the more severe disorders and they have a higher risk in the baby.
And here I would like to add one point, that the family tree should be taken, like all the family history of male partner as well as female partner, that should be drawn in details. And that should be like the history, family history is very, very important in such patients.
True, absolutely, ma'am. If there is a history of any known genetic condition, or it comes up in the family tree, then definitely, this couple, we would not like to do carrier screening. We would like to definitely screen for, we will do a more wider screening, which encompasses the genes that would be included there.
Yeah, so whole exome sequencing, even though expensive, but it tested all the 18,000 genes. Clinical exome will test basically 10,000, and carrier screening, couple carrier screening, it will test the basic 1,000 like muscular dystrophy and all the common genes. So just for screening, we can do the couple screening, but that will become with a reasonable cost also. So this patient then, this another patient came, lost the baby with the history of HLH, hemophagocytic lymphohistiocytosis. So investigation parents were found to be carrier. Now they want another child free of that disease. So all these scenario, thalassemia minor, sickle cell anemia, consanguineous marriage, donor want genetic. So we can do in these patient diseases the PGT-M. So PGT-M is when we have for single gene defects. So all this genetic counseling, we all know we can do for HLA typing also PGT-M. This all we have already discussed. Counseling is very, very important. Genetic counseling is very, very important before doing PGT-M. So what workup is required, Dr. Manju, for PGT-M?
So
how
for
much time frame is required? What work counseling is required, PGT-M cases?
For PGT-M2, we required a detailed counseling about the single gene disorder. Basically, we used to map out in these cases, and usually we know the family history. There is a problem in either of the family and in the partner, and we try to map that. We do with the fish if they are the carrier, basically, and if we can transfer, but if they are homologous, we can discard them. And same the error and the type of error is less in those cases. And in these cases, specifically, we are doing embryo biopsy and we find the euploid embryo, we go ahead for the transfer. And in these cases, but we not recommend screening double marker and IPT. We should go ahead for CVS and amniocentesis in the pregnancy if possible, to confirm the diagnosis, because these are the screening, and these are in these tests, there are high level of self-correcting hypothesis also. There is a false positive and false negative results are also, and patient want a healthy baby. So we need to do amniocentesis or CVS in pregnancy if they conceive.
Yeah, so very, very important to do invasive testing, and time frame 2 to 2.5 months is very, very important. Unlike PGT-A, in these PGT-SR and PGT-M cases, we involve genetic counseling, very important. They make the probe of the same genes. So probe formation also take around 1.5 to 2 months. Then only they do the PGTM. So this
Dr. Niru, we are running short of time. Can you please wind up and take a message?
Yeah, so this all about the managing disorder. So we can do for all these disorder like hemophilia, hemoglobinopathy, cystic fibrosis, all these conditions. So I think we are end with this. Now lab requirement we all have done. Now Dr. Jyoti will tell about the male factor. Yes, Dr. Jyoti.
Coming on to the male part quickly, we have only 5-10 minutes to discuss this. So since this is a case where they have conceived, this couple, Mr. AB comes, he is 32 years old. They have been married for 5 years. They have conceived twice, the second time with the IUI, but they had miscarriage at 7 and 9 weeks. So that was 2 and 3 years back. A DNA was done, but there was no POC or no karyotyping was done for this couple. And now this person again comes, this is the third, for the third conception, they are now trying to conceive. And in the male, actually there is on a detailed history, there's nothing, no history of diabetes, hypertension, thyroid disorder, smoking, taking alcohol occasionally. His average build, average weight, growth is normal. There's no gynecomastia. Local examination is normal. Testes appears normal in size. The semen analysis is a little worrisome. And here the count is 8 million, 40% actively motile and 10% normal morphology. A second report again shows something similar, and the DFI is 28%. So Dr. Sangeeta or Dr. Seema, whoever is there, would you like to order further investigations for him looking at his semen report? And
Yes,
what all? Yeah.
Yeah, Dr. Jyoti, we will investigate further this patient. We have to find out. So we will go for ultrasound to know if any varicocele, do our hormonal assay to know. We will do his FSH, LH, testosterone, and we will go for further tests for semen, and we will look at the sperm survival time and do the fragmentation test for the sperm.
Absolutely. So we do this, since we are focusing on DFI, so I would like Dr. Manju Daga to throw a light on this, whether you do DFI in all the cases that come to you for infertility treatment, or you do it selectively, and does it have a role in recurrent pregnancy losses? How do you interpret DFI? What exactly makes, what DFI figure makes you think and that they should be taking for treatment, and what are the indications for you to do a DFI, Dr. Manju?
Dr. Jyoti, I lost the connection in between. I didn't,
so
not able to hear your
whether-
case, but I can go ahead with the question.
Yeah, basically there is, everything is normal in female. The male we are investigating, and the sperm parameters are low, and the DNA fragmentation index is more than 25. So I was trying to ask you whether you are doing a DFI in all your cases of infertility, male infertility, or whoever is, or selectively you're doing, and how do you interpret? What are the indications when you would do it?
Okay. So DNA fragmentation test is basically we are doing for to know the health of the sperm. Sometimes we find the sperms looking normally very good and healthy, but there is some damage in the genetic material in the head of the sperm. So we want to know the health of the sperm basically. So we do DNA fragmentation test. We will not do in all cases, but we'll do in selective cases. Like when there is a age of the male is advanced, more than 40 years, when there is a unhealthy lifestyle, like patient is suffering from diabetes, patient having smoking and alcohol and obesity is there, and there is some cancer or taking some other radiation or anti-cancerous medicine, there is recurrent implantation failure, and there is a recurrent miscarriages also, there is recurrent IVF failure. So in these cases, we go ahead for the DNA fragmentation test. We also recommend the test when we see the lab data. Basically, we'll see there is a poor fertilization. We'll see when there is a arrest of the embryo. Suppose we find 20 oocytes and we able to get only 2-3 blasts, and we find egg is good, and there is most of the time there is arrested the day 3 of the embryos. In those cases, we definitely recommend the DNA fragmentation test.
So I think that we lost connection with Dr. Manju. I think there's a power failure at her end. So anybody would like to give us the interpretation of the values of DFI? Dr. Seema, Dr. Sangeeta, if you are there, Dr. Sakshi, anybody can, how do you interpret the DFI values?
Sakshi has not been involved. She can give rest answers.
In DFI test, when we see, then if the DFI comes to be less than 15%, that patient has a good fertility potential. More than 25%, it means a poor fertility potential. And 15 to 25% is average.
Yeah, so if anything more than 25%, then we should treat this patient, because all the studies do suggest that we have to, anything more than 25, we should be treating these men. Now, Dr. Sakshi, would you like to give us a brief outline of the test that we do for DFI?
Yeah, there are various tests which are done for DFI. Number one are the tests that measure the extent of DNA damage following denaturation. And they are SC-assay, that is sperm chromatin structure assay. And the other one is sperm chromatin dispersion test, which is also called as the HALO test. So, and it basically measures the susceptibility of DNA to denaturation, that is the formation of single-strand DNA from the native double-strand DNA. Then the other tests are Recurrent Orange assay and the Comet assay. So this Comet assay is basically, it quantifies the amount of DNA damage per spermatozoa. That is these are the DNA fragmentation tests. And there are other tests that also directly measure the single or double-stranded breaks in the DNA, like the tunnel test. And then there are tests that measure the abnormality in the sperm chromatin structure and integrity, which are the aniline blue staining, then the CMA3 staining, that is chromomycin A3 staining, and the toluidine blue staining. So these are the various methods. Yes.
Right. So we have these various tests, and normally I think HALO test is something that can be done very quickly in a lab, and normal sperms have a halo around them. So the sperms that do not have the halo are the abnormal sperms. So we count those, and we can do that. Also, this Recurrent Orange with the sperm chromatin structure assay. What we do is that we treat these sperms with low pH and denature the DNA. And then we do the staining with Recurrent Orange, and we stain for green for the native DNA and red for the denatured DNA. So red and green, ratio, how we see, and this is all measured by flow cytometry. So these are something very, this is very basic that we can do. And this actually, whether in, now Dr. Manju has come back and joined us. So when you do ART, when it is your first cycle, would you like to do a DNA fragmentation test for this particular first ART cycle, or you would like to do it in recurrent ART failures only?
No, in first ART cycle also we can do if we find some indication, like if we find that motility is not very good, count is very low, patient lifestyle I told you is not good, varicocele is grade 3, grade 4, then we can go ahead for in the first cycle also. Will not guide us, but basically the treatment is only empirical, but we can counsel the patient if we land up in poor outcome.
Yeah, so can somebody, since Dr. Sonika has not joined, how do we treat this cases with high DFI? Since you said it is all empirical treatment in DFIs, anybody can take it?
So yeah, I can take this.
Yeah.
So we can, yes, some treatment we should give to the patient to improve the outcome. And in some, a few percentage of the cases, we find improvement also. In these cases, we just guide the patient to improve the lifestyle, lose some weight, because in male, obesity is also one of the main factor for increased DFI. And in cases we can give the antioxidant to the patient, we can advise the patient to stop alcohol and smoking, and we can if still the DNA fragmentation index is not improved, and if it is not the first cycle recurrent implantation failure too, then we can go for TISA.
Yeah.
One
Wonderful.
more thing, Dr. Jyoti, they have found that in varicocele patients, if you operate, though it is a very debatable topic, but they have found that DNA fragmentation has reduced substantially after the surgery.
So which grade of varicocele actually would you like to operate? Because this is also again a little
We
controversial.
normally don't. In our practice, we don't. But theoretically, going by the literature, they say that
By the recommendation also, grade 3 and grade 4 we can operate. But if we want for ART technology and for grade 3 and grade 4 also we want to improve at that much. And we should offer them to ART technology only. And for the symptomatic purpose, if they are feeling dragging sensation, pain and all, they can go ahead for the varicocele correction. And after that, you can go ahead for ART technology also, which should not wait for the improvement.
So
because by they are saying by the 1 year also there is not much improvement after varicocele treatment.
Yeah, so varicocele again only if it is grade 3 and 4 should be operated, and otherwise it is all empirical treatment that we are giving for DFI, and in fact reducing the abstinence period or serial ejaculation every 24 hours also reduces the SDF by up to 25%. So if it is sometimes what it is that these patients they feel that a long-standing semen would be better. So that is actually a myth. It increases the DFI, and thereby when we are doing when we are asking them to give us the sample, it should be only with is the maximum 2 to 3 days of abstinence is good enough time when they should be giving us a sample for IUI or for IVF, any of these purposes. And lastly, the surgical sperm retrieval is the thing that we have to follow if it remains incorrected. So the ASHRAE guidelines also, they say that the main cause of DNA damage is stress, and this seems to be exacerbated by smoking, obesity, excessive exercise. So not only that, I mean, it has to be, we have to unhealthy lifestyles. It does not have to be taken care of in these cases of RPL to prevent the sperm DNA damage. And the recommendations, the good practice guidelines, they say that in the male partner, we have to assess their lifestyle factors. And it is a conditional thing that assessing the sperm DNA fragmentation in couples with RPL can be considered only for explanatory purposes based on the indirect evidence. Now, the treatment.
One more indication, Dr. Jyoti, we can do for the elderly male also. Non-obstructive.
Yes, I told you in this indication. Yes, more than 40 years you should advise.
And diabetic and non-obstructive azoospermia.
Yeah. So this thing now the treatment for this is ICSI and the NOA and obstructive oospermia. Maybe we will just very quickly go on to proceed with the genetic evaluation in men with RPL. If we can just quickly, somebody can tell us about the Y chromosome microdeletions and the karyotyping thing in the male. Though it we are talking of, maybe we are not talking of recurrent pregnancy losses, but in azoospermia, what should be done in these cases very quickly? The genetic evaluation of a male with infertility.
Evaluation male with infertility. Okay, with infertility or with azoospermia?
With azoospermia.
Okay, with genetic evaluation. My voice is echoing, I think.
Yeah, it is echoing. Maybe you have to.
Dr. Jyoti, you please summarize and take a message.
Yeah, only 2 minutes.
So, now it's okay?
It is okay.
Yeah. Dr. Jyoti, in case of genetic evaluation of the sperm in male factor in RPL cases, we go ahead for the karyotype of the male to rule out the Klinefelter any abnormality in the karyotype number and balance translocation. And second is we can go ahead for the Y chromosome. If this is a azoospermia, Y chromosome long arm hem, azoospermia, AGF factor basically, there are 3 zones, A, B, C. If the microdeletion is present zone A and B, we're not able to find the mature sperm. In these cases, usually Sertoli only syndrome or maturation arrest is there. So don't go for the TISA and all these invasive testing in these cases. But if the deletion age is very factor C, then we can find sperm in these cases and we can go ahead with TISA. But we need to counsel these cases. This can be transmissible to the next generation. If they have son again in next pregnancy, then the son can be azoospermic. So this counseling is very important in these cases. And there are other genetic testing also, like GRY, autosomal CFTR gene testing. So all these genetic testing we can go. We can't go do all testing in all. We can do testing in a specified manner, like karyotyping and your Y chromosome deletion. We can do in azoospermia patient with severe OAT, a patient severe oligoasthenozoospermia patient. We can do this. But if a patient like with the congenital VOS difference, then we can go ahead with CFTR testing. So we can find the case-based testing in these cases, and we go ahead for the testing.
Wonderfully, very nicely, Dr. Anju has explained to us. So in nutshell, we should be taking care, we should do the karyotype and the Y chromosome microdeletions in these cases. In karyotype, we can rule out the Klinefelter. In Y chromosome microdeletion, if it is in AZ, I'd shown this one, if it is AZFB, then we will not find sperms. So there is no need of doing TESA, anything. No need of doing any biopsy. If it is only if AZFC, then only there is a chance, there is a very good chance that here in these cases, we will be able to find sperms, and their sperm retrieval techniques, surgical sperm retrieval should be done. And not only that, because we can say outcome prediction can be done by doing gene testing. We can see the transmission to the descendants. We can do the PGD and prenatal diagnosis in those particular cases. And also not only that, it has an effect on other things also. There are a lot of cancers that are associated with these cases in these alterations in these genes. So we can always take care of that. And surgical sperm retrieval techniques, we have these various techniques. We can do it from epididymis, we can do it from testes. It can be open biopsy or it can be percutaneous aspiration and all. And we can vitrify these sperms. We can do micro TSA. So micro TSA is also something where in TSA, if we are not able to find sperms, micro TSA is something where we can find sperms in these patients with Klinefelters, with hypogonadotropic hypogonadism and all that. And in a review, this even if we take sperms from testes or from epididymis, there is no difference in this latest review of these 1100 men with obstructive azoospermia. It was seen that the miscarriage rates did not differ, whether it was an epididymal sperm or it was a testicular sperm. So thank you so much. Thank you. And I would like to thank Dr. Nandita Palshetkar and Dr. Sujata ma'am for giving us this opportunity, and Haryana ISAR President Dr. Chugh and Dr. Rakhee, the Secretary, for bringing up this wonderful topic of genetics and giving us this opportunity. Thank you so much. On behalf of Haryana ISAR, I thank you all for joining today. Thank you.
Thanks everyone for joining. And now I would request Dr. Rakhee to officially say a vote of thanks to everyone. Dr. Rakhee?
Yes, ma'am. First of all, I really thank to my chairperson, Dr. Renu, who has been always so motivating, so innovating ideas and helping me always to coordinate this webinar. And I request all the two speakers, Dr. Isha and Dr. Sujata. Dr. Sujata, you have been so motivating us and giving us this opportunity to hold this topic. And Dr. our moderators of the two panelists, Dr. Manisha Mehta and Dr. Maninder, and Dr. Jyoti and Dr. Niruthakra for moderating such a beautiful panel. And we have such a nice panelist in all the panelists, Dr. Savita Singhal, who came just once and just vanished away. I think there was no connection. Still, we thank you for making the effort. Dr. Dipika, Dr. Dr. Rebuna, Dr. Manju Dagar, Dr. Sangeeta, Dr. Seema Mittal, thank you from the Haryana chapter of ISAR. We thanks for making this webinar a great success and hoping for more in the future. And our chairpersons, Dr. Dipika, Dr. Jitender, and Dr. Anita Narula and Dr. Chanchal Dhir for sparing your valuable time. And we're hoping in near future we'll be holding a annual conference of Haryana chapter of ISAR. So let's get up and we'll soon get a consensus on some date, and then we'll get back to you. So thank you so much. Thank you so much.
Dr. Punita, Dr. Manisha, and in the end, JB Pharmaceutical Company, lots of thanks to you. Now over to you, Mr. Amit and Dr. Dipika. Over to you, please.
Thank you very much, dear faculty and attendees, for joining us today. And now we have the ZSM from Chandigarh region, Mr. Sandeep Thapar. He will be addressing our gathering here today. Sandeep ji.
So first of all, good evening to all esteemed faculty and attending doctors. My name is Sandeep Thapar. I am working here as Zonal Sales Manager. And I am here to present briefly my 3 brands to all of you. My first brand is DIVATRONE. DIVATRONE is a brand of Dydrogesterone 10 milligram tablets. And I want to highlight just 4 points of my DIVATRONE. First is, it is fully indigenized in nature. That is from raw material to excipient to final product. Everything we are manufacturing at our own plant. Micronized in nature for better absorption and faster onset of action. And thirdly, the shelf life of our brand is 36 months, which ensures better stability as compared to competitor brands. And lastly, our brand is patient friendly and very cost effective. It is just 50 rupees a tablet. So I will request all the doctors to recommend our DIVATRONE in recurrent pregnancy loss cases, threatened abortion, luteal phase supporting IUI, and IUGR cases. And second brand I would like to highlight is Dr. Dipika, second brand. Second brand I would like to highlight is Maintane. Maintane is a renowned brand from last 30 years in the Indian market, is a brand of hydroxyprogesterone. Please continue to prescribe our Maintane to maintain pregnancy till term. And our third and last brand is Recurrent Preg, a brand of combination of L-arginine, lycopene, and DHA. Best thing about our Recurrent Preg is it is sugar-free in nature and totally from vegetarian sources. So once again, I am thankful to all the doctors to attending this webinar and hope to see you again. Thank you.
Thank you.
And
thank you so much. Thank you so much for organizing this webinar from Haryana chapter of ISAR. We are so thankful to you.
Needless to say, we'll all support you. Okay, thanks a lot. Thank you very much again.